Dear friends, colleagues, it's the first time in the history of ECC where I can tell good morning, good evening, and good afternoon at the same time, and everybody will hear me according to his place. This year we are meeting for the first version of the Emirates Critical Care Conference, ECC Dubai, which is supposed to be the 15th. That virus that teaches so many new things, not only in our life, but also in our science, the knowledge, the field in which we are specialized, which we thought that we are capable enough to face the most difficult, the worst cases. This virus, which made some people change their topics. Some said, we found out that smoking prevents. Some who said, we found out that if your immunity is big or strong, that's negative because you will be affected more by the storm stage. And many other thoughts, which we start to revise. The virus which contained us, who taught us stay safe by staying at home. Maybe taught us also the value of our families, the value of protecting families in a way that we used to protect others. A time where we came to know that one of the most emotional events, hugging, is prevented, who showed us there are more valuable things in life to show our passion rather than only hugging or shaking hand or coming close. He contained us, though our idea of fighting this conference is by containing him and containing the people who infected by this virus. A virus who changed our concept of dealing with acutely ill patients, dealing of how or what are the ideas of ventilation, revising our approach. Is it really the desaturation that matters? Where we saw patients who desaturate up to 60, but still awake and conscious and has no complaints. The whole world came to talk about post-COVID time, the new normal life, and so on. We changed our understanding, our relations, our feelings. We didn't go to the bad time of feelings. We improved our feelings, actually. We came to discover that saving my people by staying away from them. Our doctors, our professions, nurses, who start to understand or came to learn how to undress an astronaut suit, which we thought of, it's something easy. It's something supposed to be understandable. I remember when they came to teach me and my team how to dress and undress that suit, feeling or giving us the feeling of, am I a child to learn that from the beginning? I'm not grown enough to learn how to dress or undress my protection suit, astronaut suit, how to wear my glove, how to remove my glove, the mask, which we used to look at it compulsory, accessory, it became a compulsory. Washing hand, it's not during procedures, it's not to protect patients, it's sometimes to protect us. In my hospital, I was member of the leaders of the COVID task force and the disaster committee, where we took precautionary measures, how and when and where to protect yourself by using the personal protection equipments, by using equipments that can clean the air, clean the area, clean the water, clean the food, how to maintain cleanliness in our usual day, in our usual daily movements. It's a virus that changed the world. It might be the only or the most spoken about disease in the history of medicine. We lost a lot of colleagues. We lost a lot of co-workers who really sacrificed their life to save others. Countries which were supposed to be advanced in medicine, like Italy or Spain or United States, or other European countries where we found people being lost for unknown reason. We thought, is it respiratory? Is it the defense? Is it the organ failure? The involvement of organs? The concept of sepsis, we start talking about it. Is there any difference between a viral, a bacterial, a fungal sepsis? Simply, it has just produced a new way of thinking, a new way of approach. And everybody in every country, every part of the world, start thinking to build up his own experience and his own way of approach. As we are doing this every year, a team of Emirates Critical Care Conference have worked hard to present something new, the hybrid conference, where we have people attending, where we have people online. And this first version of our conference has recorded the highest number of candidates in our history also. It reached more than 3,500. Countries where we might not hear about. I have one of the countries called Svalbard. We searched for it. It is an island near Norway. And many other, more than 60 countries involved. Everybody is thirsty to know something new. On the other side, we have collected colleagues, experts from around the world, from the 5 continents. Some of them will be speaking today, and some of them will be speaking on 28th of November, and the others will be on the 12th of December. I wish you all to gain something, put something from your side, exchange ideas like we are always doing in our conference, of Emirates Critical Care Conference. I will leave the stage for the first session, and the moderator with us will be Dr. Ashraf Al-Houfi and Dr. Asad Al-Sabah, who will be presenting our colleagues from the world. Thank you very much. Looking forward and wishing you that enjoy and get the best benefit out of the meeting and the speeches. Thank you. And on behalf of everybody, I would like to welcome you on the first Emirates Critical Care Conference, the first hybrid. It's the 15th ECC Dubai. I wish you enjoy. Thank you very much for attending or for registering online. Thank you.
Thank you, Dr. Hussein. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hussein, for this introduction. You remind us with the good old days, and hopefully we will go back again to our physical conferences again. We are starting our first scientific session, and it gives me a great pleasure to start with our first speaker, who is Professor Ng Shin Wai. He is a senior consultant in anesthesia and intensive care, and the head of the Department of Surgical Intensive Care, the Division of Anesthesia and Perioperative Medicine in Singapore General Hospital, Singapore. He will be talking to us about airway management during COVID-19, Goldilocks zone for infection control. Professor Ng, the floor is yours.
Greetings from Singapore. First of all, I'd like to thank Professor Hussein Al-Rama, as well as the scientific committee of the first Hybrid Critical Care Conference for inviting me to give this talk. My name is Ng Shin Yi. I'm a critical care anesthesiologist practicing in the Singapore General Hospital. The SGH is a 1,600-bed hospital and is the flagship hospital of the Singapore Healthcare Group. Of course, I would much rather like to be in Dubai in person to attend this conference. However, the COVID-19 situation does require us to communicate with each other remotely. Still, I hope that we will be able to meet up in person soon. I have no conflict of interest to declare. Okay, during today's talk, I hope to talk about the SARS-CoV-2 virus and the understood modes of transmission. And in doing so, explain how it might affect airway management for us. I will elaborate on the risk to the healthcare workers as well as the need to achieve adequate protection. In doing so, I also would like to highlight that we need to achieve a balance between the risk of infection to the healthcare workers against performance degradation in the choice of PPE. And I will walk you through some of the thought processes we have had at SGH in deciding how to achieve this optimal balance. Many of us are familiar with the SARS-CoV-2 virus by now. In the initial stages, we thought that it was a largely droplet-borne pathogen that was deadly, causing high morbidity and mortality to people it infects. Now we're starting to understand that actually the presentation and phenotypes of the COVID-19 infection is widely varied. However, there's still a group that is at high risk of mortality and morbidity. And therefore, there's this need to ensure there's adequate protection. In the initial phase, we started to see a lot of evidence of aerosol spread. Nonetheless, the evidence suggests now that most infections are still spread by close contact rather than airborne precautions. This is because the R0 or reproductive number for this virus is actually only about 2 to 3, which is consistent with other droplet spread pathogens. In contrast, the R0 number for airborne pathogens such as measles is actually 16. Therefore, the main driver of transmission is likely to remain that of droplet spread. Nonetheless, airborne transmission has been shown to occur under special circumstances, such as that of prolonged exposure in enclosed spaces which are inadequately ventilated. In the non-clinical setting, that will be largely during social interaction at home or at work, when people are not wearing masks and close contact with each other. In the clinical setting, that will obviously involve prolonged care of the patient, and a lot of time it will be also during airway management. So this whole study actually attempts to quantify the risk of transmission of acute respiratory infections to healthcare workers during aerosol generating procedures. There are many procedures which, in theory, as well as practically, do aerosolize pathogens, but not all of them are equal in spread of virus, in transmitting infection. So in this study, tracheal intubation as well as non-invasive ventilation are found to be of high risk in transmitting infections, while other procedures such as suction, nebulization, bronchoscopy, and nasogastric tube insertion, etc., while there have been documented case reports and maybe some small case series, there have not been overwhelming evidence that they are main drivers of infection. Therefore, at this stage, our understanding of the literature suggests that the main driver of SARS-CoV-2 is still largely droplet spread. And hence, therefore, in low-risk environment, as well as non-clinical environment, the PPE measures should be that directed towards droplet spread, such as wearing surgical masks and social distancing. However, for airway practitioners like us, during airway management, there will be airborne spread, and this is at high risk, and therefore, PPE management during this stage must be directed against airborne transmission. And we need to recognize that not all AGPs are equal in risk for aerosol generation. Okay, bringing us back to the earlier stage of the pandemic, the medical teams in Wuhan actually published this very well-read study about their experience achieving tracheal intubation in their patients. Basically, they form an expert team of practitioners who had standardized equipment and protection who underwent regular drills and did all the intubations in their medical centers. This reduced the variation of care and increased success, as well as reduced the risk of infection to the healthcare providers. When we read the article, we were very impressed with the amount of PPE they wore, which was basically almost the entire body was covered. And they were also wearing a powered air purifying respirator, otherwise known as a PAPR, for all their operations. Compared to Singapore, this is our recommended PPE for all our healthcare workers, which is largely consists of an N95 mask, goggles, as well as protective gowns and gloves. While in the early stage of the pandemic, we were worried that we were going to run out of PPEs. Fortunately, thanks to our stockpiles achieved as a result of our experience with managing the first SARS outbreak, as well as a whole of government effort to secure the supply chains, we never really had a PPE problem. Nonetheless, for a lot of healthcare workers, if you look at what our colleagues in China were wearing compared to what we were getting in Singapore, there was of course a strong feel that we were inadequately protected. And so the question we ask ourselves is this true, and how do we know that? This question frequently came up in our discussion with our staff, is how much barrier is needed? Do we need to cover every single skin of the body? And then do we also need a PAPR in management of AGPs? PAPR was a big issue in Singapore because although we had a reasonable stockpile from our days managing SARS as well as the H1N1 pandemic, many of the equipment were old and a lot of them had high failure rates. Early on in the pandemic, we actually ordered a lot of PAPRs, but due to supply chain limitations, none of them actually arrived in time. In fact, now they are starting to arrive. The risk to healthcare workers is not insignificant, especially during airway management. So this is the Intubate COVID study that was published about 2 months ago, which was a self-reported study of acquisition of the COVID-19 infection following airway management. Of note, about 10% of note, the use of PPE among the respondents of these studies varied widely. Although 87.9% of them conform to WHO recommended minimum standards, we find that the use of N95 masks as well as PAPRs among the centers were not high, and this might be due to various reasons. At the end of the study, 10.7% of the patient population, of the healthcare workers actually developed the primary endpoint of a laboratory confirmed COVID-19 infection or symptoms requiring self-isolation. Therefore, the risk of infection to healthcare workers is not insignificant. And this study doesn't take into account asymptomatic infection because it was conducted early on in the pandemic when the understanding of the disease was not so high. We try to understand how much, what is the burden of COVID-19 infections in our Singapore healthcare workers so far. As of today, there are about 58,000 COVID-19 cases in Singapore, of which about 150 of them required invasive ventilation in the ICUs. So far, as of publication of this study, about 88 healthcare workers have been documented to be infected, many of them from the front line. However, we could not find any cases that were transmitted during airway infection. Most of these cases could be linked to social interactions in both the family as well as workplaces. We also note that a lot of these infections actually occurred not in the medical or nursing staff, but in the ancillary workers like the janitors and the cleaners, who, while they were provided and trained in PPE, may not have the degree of experience and discipline as the medical and nursing staff. Besides COVID-19 infections, there was also a huge psychological risk and burden on our healthcare workers managing these patients. For example, the medical officer who managed the first case of COVID-19 in Singapore, which was an imported case from China, developed symptoms shortly after exposure to the patient, and we actually had to isolate him. However, further investigation actually found that he was not infected, but he was just at a lot of stress being exposed to this patient, although he was wearing PPE. So we recognize that healthcare workers need to be protected well, especially in high-risk procedures such as AGPs and intubation, as healthcare workers are force multipliers in the pandemic, and losing a healthcare worker either through infection or quarantine will reduce the resilience of our medical force. In this article that we wrote early on in the pandemic, we actually suggested that PAPRs are to be won so long that there's AGPs done. And you can see early on in the pandemic, even when the healthcare workers are transporting a ventilated patients on a closed circuit, they were wearing PAPRs because they were worried that there could be a circuit disconnection and therefore exposure. In our paper that we published about operating room procedures during the COVID-19 pandemic, we also recommended that PAPR be worn at all times, even after the airway is secured. And this is so that nobody feels that they are at risk during the infection. Although we recommend that after the airway has been secured and a certain amount of time has gone by for OT airway turnover to occur, the staff could step down to normal PPE without PAPR. No staff actually were willing to do that during the early days of the pandemic. So therefore, we recognize that healthcare workers are at risk of COVID-19 infection during their work and especially during airway management. The fact that there were differing PPE standards internationally as well as even within different institutions in the country caused a significant degree of unease among our healthcare workers. It is important for healthcare workers to be adequately protected and to feel adequately protected so that they can do their work effectively. Nonetheless, the key of my presentation is to say that more PPE is not necessarily better. I will go on to explain to you how, review the literature on how this may actually lead to reduced performance. Also, the act of putting on and taking off PPE can also lead to contamination of other healthcare workers as well as environment, and therefore requires a lot of training. I will briefly note that there has been a tremendous increase in biohazardous waste generated due to care of COVID-19 patients. And if this pandemic is going to continue for the next few years, we need to find a solution that is more sustainable and environmentally friendlier to proceed. The use of PPE as well as procedures to ensure that the environment doesn't become contaminated and is clean between procedures will increase turnover time, which will reduce the efficiency of our healthcare system, which prior to the pandemic are often already working at breakneck speed. If we need to maintain care of our baseline patients, then we need to find a rational way forward. So this study from Singapore actually showed that wearing PPE does increase heat stress, thermal stress among our healthcare workers. This is especially if you're working in tropical countries or in areas where there may not be air conditioning or inadequate air conditioning. The wearing of PPE during airway management also degrades performance. So this is a study performed studying emergency medicine residents and pre-hospital providers in the days before COVID. And they found that wearing PPE decreases first pass success at intubation as well as increases time to intubation. While many of us would like to use a video laryngoscopy for airway management during the COVID-19 pandemic due to increased operator and patient distance, there was no difference in performance noted in this study. PAPR remains very popular and is often something that all our staff want to use. This is on the left is actually a checklist that we hang out in all our areas for staff who are donning and doffing of their PAPR. And you realize that this is actually a very, very long list, which is hard to adhere to unless you are wearing it every day. So use of PAPR is associated with a longer donning time and therefore a slower staff activation. There's increased protocol violation, and therefore we frequently need to put a spotter to help the staff use it. There's reduced performance and difficulty in communication, and frequently our PAPRs break down, and therefore failure drills are required. As our new PAPRs come in, this may not become an issue. A brief statement about aerosol boxes, which are barrier enclosures to protect the operator during intubation. In the early stage in the pandemic, they were very popular as due to the lack of PPE, and they were thought to afford earlier more protection. In Singapore, many of us tried to come up with our own aerosol box. However, the recent literature has actually shown that it reduces first pass success, increases intubation time, and may damage conventional PPE. The operator also usually find them difficult to use, and it does reduce their performance and increase cognitive load. The only aerosol containment devices that have been shown to succeed are those with an associated suction device to evacuate the air. Otherwise, the other devices may be associated with increased operator contamination. Okay, so at this stage, I would like to take the audience through my thought process on how to figure out what is the Goldilocks zone for airway management. We need to balance the fact that our healthcare workers are at risk during airway management, and we need to protect them adequately. And we need to balance it against the risk of PPE use, which may reduce performance and reduce efficiency. And hence, we need to try to find out what is the Goldilocks zone to operate in. In Singapore General Hospital, we have a strict protocol for risk stratification of our patients. It's mainly due to we look at the epidemiology risk. Where is the patient from? Currently, the main epidemiology risks come from patients who are coming from overseas, as the local situation is well controlled. And therefore, we balance it against the clinical presentation. How likely is this patient to have COVID-19 based on this clinical status? Then, after that, we seek to confirm our diagnosis as early as possible by doing accurate and fast rapid testing to determine the status of the patient. We look at the procedure the patient is undergoing, especially whether the patient is undergoing aerosol generating procedures and what kind of aerosol generating procedures. Are they the very, very high risk group, such as airway intubation, or is it something a bit lower risk like nasopharyngeal suction? Looking at epidemiology risk profile, clinical presentation, as well as procedure, we have a very extensive list to determine where this patient will be cared for and what is the type of PPE that is going to be used in this patient. And this list is constantly updated for all the staff to use. Therefore, in doing so, we attempt to stay in the Goldilocks zone and balance the protection of the healthcare worker against performance degradation and reduced efficiency associated with PPE use. By having careful risk stratification and early and diagnostic testing, we are able to identify the patients and match them to the appropriate PPE use, such that we keep our healthcare workers protected, yet on the other hand, try to maintain as much efficiency and performance in the system as possible. In doing so, we hope to create a long-term and sustainable strategy for our healthcare system to manage this pandemic, while at the same time continuing to manage our already heavy baseline healthcare delivery as we await this pandemic to be over, or if it's going to be something that's going to be with us for the long term, learn to live with it. So with this, I hope I've given you some insights into my thought process, and I welcome any questions from the audience. Thank you very much. Greetings from Singapore.
Good afternoon, ladies and gentlemen. Greetings from the UK. Thank you to the organizers for inviting me to talk at this prestigious conference. COVID-19 has certainly changed our lives. More than 50 million cases worldwide and 1.25 million deaths. I will be sharing my experiences during the first wave of the pandemic, what we have done to improve communication between families and patients and staff, and our bereavement meetings. This is entirely a practical lecture and will add an extra human touch to all the scientific meeting in the lectures. I wonder whether our listeners have had similar experiences and whether we could share our experiences later. So what happened before the pandemic? We were all worried, is it really going to come? We were hearing about China, Singapore, Italy, whether they would be planning lockdown. We were really, really scared. Whether we would get enough PPE, whether we had to close down theaters, elective surgery, will emergency continue? So we had to plan. We have 9 level 3 ICU beds. We needed to increase it to 50 beds. That's a lot. There would be red hot theaters and green theaters. We had to equip all our theaters and recovery room to convert them into ICU beds. We required more equipment, more ventilators. Would they be available? Would anesthetic ventilators be used? Drugs? What about the pumps? And most important, staff planning. Usually nurses look after 1-to-1 patients. We required them to look after more than that, 1-to-3 or sometimes 1-to-6. Theatre staff and staff from other areas who were unfamiliar with ITU were going to be deployed in our areas. Orthopedic surgeons needed to be trained to prone patients. Our trainee rota needed to be changed. They were fantastic. They went into teams and they worked extra hours. And so did we seniors. We went on to 12.5 to 13-hour shifts, 3 days on, 3 days off. And all other staff also needed to be involved. One of our consultants started PPE training, airway management training, as well as crisis management. And the most important thing we knew was that we had to work in a team together. Reality then struck. First cases started coming around mid-March. They were really, really unwell, rapidly increased, and the peak was around the second week of April and continued till the second week of May. We went to 3 times our capacity for ventilated patients. All elective surgery was stopped, and theaters and recovery was converted into intensive care. But we ran a non-COVID ICU as well. This is my picture in the Teletubbies. This is the hazmat suits and the PPE. I really felt safe. Our hospital gave us good PPE, and thank you to our procurement department for this. What have we done well? We have been working in unfamiliar circumstances, and everybody worked together wonderfully as a team. Hats off to everyone. We expanded to theaters. We had a COVID and non-COVID ICU, and very low amount of sickness thanks to the PPE. And we were well looked after by the catering services, the public and the restaurants. What were my concerns then? It's an unfamiliar environment for all staff. Long, tiring shifts, unprecedented crisis, unknown disease. And it was a really overwhelming feeling when a patient dies in front of your eyes, when you've tried everything. And I've asked colleagues and friends around the world, they echo what I feel. Communication between inside the COVID and outside the COVID ICU was difficult because of the PPE, because of the barriers. Self-blame. We tended to blame ourselves when somebody died, whether we could do something more. We had to support staff and trainees. One of the staff came and asked me, Nandita, do you feel vulnerable? Do you feel, do you self-blame? And I said, yes. And she was crying then because she was also scared. Fear of catching infection, fear of infecting your loved ones. Did you all feel this? Will it come again? COVID is not going completely. We are now in the second wave. How long is it going to continue? Fear of PTSD, nightmares. I didn't sleep for 2.5 months properly, and people have been having sleep disorders. They're becoming more irritable and exhausted. But what we have learned from all this is that teamwork is very important. Without a good team, you cannot do well. Good leadership and planning, Most important, communication between the staff, between doctors and nurses, between doctors and patients, between nurses and patients, and everyone is very important. Good PPE matters. And the last two factors are really, really important. It is an unprecedented crisis. There are lots of unsupported, confused, and scared people. We have to support each other, our staff, patients, and the most important, the families, because there's not much research into this, quantitative research, and the families are sometimes left out. And a paper by Martin et al. In the Journal of Pain and Symptom Management says that the acute grief reactions are much higher during the pandemic. So what did we do to improve experience? Remember, no visitors were allowed, and later one visitor was allowed when the patient was dying just 15 to 20 minutes before they died. So we used to ring up families every day, at least once a day. The doctors used to ring up and regularly update them. I used to sometimes ring up more than once and explain to them what was happening, and they were really thankful to me because I could feel their anxiety and helpless feeling for not being at their loved one's bedside. One extubated patient thought I was an alien, and the nurses were alien as well, and so we had to reassure them. I used to sing and dance sometimes with the nurses just to keep up the spirits. We used to do prayers, chanting. We cried at times, hugged each other, and encouraged each other. But the family communication was really important, but it was difficult to do that from inside the ward because we had to maintain, again, the cleanliness and hygiene. So what did we do to support the families? As early as April 2020, we started a link between the families, patients, and the nurses. We gave hearts, mementos, friendship bracelets, cards were sent by post or delivered by the nurses to the residents. Families sent in photographs, pictures, and messages which were hung around the patient's bed. I will show you that this is me form later, which was filled in by the family. If there was a bereavement, the families were rung up by a Macmillan nurse as a cancer nurse who came to support us and gave information on the next steps, how to get a death certificate, how to find support, links to counseling services, how to arrange funerals, whether they required any more help. And he was really, really great. Now, this is the me form. This has been there for a long time, but it was really used mainly for the nurses because the nurses were looking after more than one patient. This has got all the details about the patient, what I prefer to be called Bob, Rob, whatever it is, my immediate family members, what is more important to me, my life so far, where do I live, my dislikes, what TV programs I like, whether I have speech disturbances, hearing problems, sight problems. So what are the personal needs? So the nurses could know better about the patients, and they felt that they were more in contact because the nurses were finding it really hard that they could not be in contact with the patients. Families usually they are at the bedside. We send these cards with messages, lovely messages. We sent hearts, we sent friendship bracelets, as many as required, and information for the kids as well. Then letters were sent of the bracelets. So we then set up virtual contact and Skype service. Why? Because no visiting was allowed, no patients' relatives at the bedside, no face-to-face discussions, no closure. Shock, disbelief on the part of the family. One lady did not believe that her husband had died for 15 days because she hadn't seen the body, because there was no hand-holding. We had to reassure their families that we will not allow their loved ones to die alone. We will hold their hands. We will pray for them. We will not leave them. And that was reassuring for the families. Their patients were looked after. Nursing ratio, as we said, was low. We needed regular contact and communication. So what happened? One of the senior sisters actually went and secured tablets and devices, and she got permission from governors because of confidentiality issues. We assisted families to download Skype and assisted them with technical issues, regular contacts, twice a day as permitted, clinical and non-clinical staff help, and during end-of-life support, non-clinical staff also, one of our managers and secretaries volunteered to come and help the families. We had one family, young family, with a young husband dying. Just before he died, the wife talked to him for a long period of time. The daughter said a poem and also showed her pictures. Then we stopped the Skype. The patient then died. And then again, we reconnected. And we've kept in touch with the family after the death as well. This has happened with quite a few of our families, and families got a lot of comfort. These are our Skype angels. Our secretary, as we said, they did a great job. They volunteered to come in, and they were recently awarded the Hospital Heroes Award. Got lovely Skype messages. This thank you message, I have an image of the person, and she's settled, mind blown, how kind you all are. Thank you for doing so much, everything for my dad. Thank you, we are grateful. And you know, amazing, amazing messages, very emotional, very overwhelming. Again, some more messages about supporting our dad. I would be, you know, thankful that I got to be with my dad, to be able to hug him and hold his hand meant the world to me. This is really great. So bereavement meetings, exhibited by Sue Morris et al. Sorry, rephrase. A paper by Sue Morris et al. In the Journal of Pain and Symptom Management says that the death of the loved one is considered to be the most powerful stressor in everyday life, with individuals at increased risk of adverse mental and physical health outcomes. And risk of poor bereavement includes a lack of social support, a sudden traumatic death, a hospital-based death, lack of preparation, and a death in ICU. So we are dealing with ICU. Several risk factors for complicated grief reactions, such as prolonged grief disorder and post-traumatic stress disorder, including a patient dying while intubated or not being at the bedside to say goodbye, and poor communications. This was stated by Lundorf et al. Again, in the prevalence of prolonged grief disorder in adult bereavement. During the COVID pandemic, it has been highlighted that there is a gap and there's a sense of urgency from a public health perspective for institutions to provide support to bereaved family members. COVID-19 deaths are characterized by poor bereavement outcomes and prolonged grief disorder and PTSD and mental health because of lack of access to visit, self-isolation, no one to talk to, or too many people in the house, lack of outside support, and mainly no traditions followed because there were no priests or chaplains who could go in. So we had to do that for them. 6 studies have been identified which provided evidence on system responses to bereavement in the aftermath of many human-made and natural disasters, but there are no studies which describe bereavement support programs in the context of pandemics. Several key factors like proactive outreach to those in need were identified. There needs to be a central coordination of locally delivered support, and we have to draw from group-based support or use of existing social networks and refer them to specialist mental health support. We have done something locally, and this has been stated in 2 wonderful papers by Mayland et al. And by Selman et al. So what we did as for our bereavement meetings, we planned for both, remember, COVID and non-COVID deaths. After the demise, there was a phone call to give them all the information, but to ask them whether they were okay. Can we do something for you? And also, we said that whether you would like to speak to somebody, speak to a consultant. When did the meeting start? Though we had planned them early because of time commitments and because of how we were busy, we started them in August. We've held about 20 meetings, out of them 5 face-to-face. There is no time limit. We set it up for about 30 minutes, but my last meeting went for 1.5 hours, where the patient's family just was talking. We just listened to them, and a listening ear was great. They were really grateful. There were lots of tears, lots of questions. We tried our best to answer and refer them to the counseling services. What were the common themes? Was my husband in pain? Was my wife in pain? Was she distressed? Were they aware? Were they all alone when they died? Who was with them? Can we speak to them? Why my family member, he went walking into the ambulance and then ended up dying. We didn't receive much communication from the hospital. We received, what communication we gave. Patient is stable. What does that mean to them? Are they actually stable for 2 hours, 10 hours? And why then suddenly somebody dies? Are we giving them the right information? Are we training ourselves to break bad news in a pandemic well? Why did they deteriorate so quickly? And will my other members of family die? My grandchild, he's only young, but he's not well, he has fever. Will it be COVID? Will it be die? Because there are people who lost multiple members of the family, 2 members. And she was distraught saying, oh, doctor, please, can you tell me that my grandson won't die? So that was really bad. So bereaved people have developed new resources and we draw on existing support. So we have formed a new group for these families. This was formed on the October 23rd this year. We had our first meeting, attended by 6 families, 2 nurses and a counselor. There was a long talk, tears, discussion, exchange of contacts. We have now planned monthly meetings. We then refer them to the counseling services. We don't have money for it, so we refer them to charity services or local government. And we will have further meetings to focus on various themes. So in summary, COVID-19 has changed the way we live. We have learned the importance of good teamwork, good PPE, and supporting each other. The pandemic has left health and social care systems facing the challenges of supporting large numbers of bereaved people in difficult and unprecedented social conditions. It will be associated with prolonged grief disorder, post-traumatic stress disorder, and poor mental health. Professionals and public should be proactive and develop a sympathetic, inclusive, and comfortable atmosphere for the families. We should not be forgetting the families. We should be the families for their patients. They don't have their relatives at their bedside. So we should work for them. I'm positive that together we shall overcome this. We will never forget the brave Corona warriors and colleagues who have lost their life during the pandemic. Your sacrifice will be never forgotten. Rest in peace, my dear friends. We have to look after each other's safety. I had a family bereavement. I could not go to India to see my immediate family members. I've had no closure. I feel what the families are feeling. Please share your experiences about the support for bereaved families which your hospitals give. I have my email at the beginning, and hopefully we can form a network. Thank you very much for listening. Thank you to the NHS.
Thank you, Dr. Nandita, for this excellent talk. Please stay with us till the end of the session to answer the questions. There are a few questions you can answer even now. It's my pleasure to introduce the third speaker for this session, Dr. Jamila Al-Salman. She is a chairperson of medical department from 2011 till 2017, chairperson of the Antibiotic Stewardship Program in Ministry of Health, Bahrain, chairperson of Antibiotic Stewardship Program in Bahrain, and chairperson of the Hereditary Blood Disorder Center in Ministry of Health, Bahrain. She is going to talk about antibiotic stewardship and limiting MDRO and COVID-19, what we have learned. Dr. Jamila, the floor is yours.
Hello, everybody. Thank you very much for the organizing committee for inviting me. Today, my presentation is about really a hot topic. It is COVID-19 antimicrobial resistant, antimicrobial stewardship, the new nightmare. You know, if we will talk about this topic, I think we've been talking for a long time about the antimicrobial resistant, and we've been talking that it's very difficult to predict what will happen in the future and what kind of microorganism that we are facing. But the best part of it is that we have to implement the basic of medicine is doing no harm. This is the basic. So please try to remember all the time what are the basics. So we'll try to connect it to what we are talking about in the during the pandemic of COVID-19. You know, what are these basics? You know, we all look for optimizing patient safety and have the best clinical outcomes, and at the same time controlling the cost. When we implementing an antimicrobial stewardship, we have to keep all of this in mind. And COVID-19 is not an exception. Antimicrobial stewardship basic is the right agent, right dose, right time for appropriate duration. But before you decide about the right agent, you have to have the proper diagnosis to make it right and to go in that road. So in COVID-19, actually, it's quite complicated because we are dealing very complex cases, and actually it's sometimes difficult to differentiate between bacterial or even just the pure viral infection. So what we know from the past, our actual experience with the MDRO, we know that it's a major problem. 10% hospitalization are complicated by healthcare associated infection. And there is a increasing actually rate of morbidity or mortality. What are these organisms? The well-known, the ESBLs, the CREs, the Pseudomonas, and the Acinetobacter MDRO. So they are the same, they will not be different in the COVID-19 era. What are these organisms can cause for us? Actually, it's most of the ICU admissions. And there's one thing peculiar when we try to think about the COVID-19, is that these organisms are coming on those cases, COVID-19, who are admitted to the ICU. So COVID-19, and not only any case, it's the COVID-19 ICU. So you'll see the same thing. You'll see your Pseudomonas, Acinetobacter, and your CRE and ESBL. And we know from the previous experience that this organism by name does not make a big difference. But when we talk to when we see the pattern, actually, when you have more resistant organism, actually the mortality is higher than what's sensitive for the same organism. So it's not only having Pseudomonas Acinetobacter, we know it has to be an MDRO to really push your mortality higher. So what are these factors? The same factor we saw before COVID-19, they are with us right now. When we talk about inappropriate treatment or any risk factor that we can modify, any patient who gets admitted or transferred from our other hospital, and that's what we see now, we are getting patients from all over the places. Prior antibiotic use, yes, most of them, they get actually antibiotic on the day they get admission to the hospital. And they have other comorbidities with it. Most of our especially aging population with the COVID-19, they have other comorbidities. Don't, please forget the collateral damage. Any antibiotic, I know that all our physicians, they say, patient come from the community with COVID-19, they have to be covered for community acquired pneumonia. But even using the third generation cephalosporin or quinolones are really not good for long term. And we know that our patient in the COVID-19 ICU, actually they stay on average, 11 to 14 days most of the time. So they will be exposed to this antibiotic and they're at higher risk of developing those MDRO. So what we have in the Gulf region, it's not the whole world, only in the Gulf region, we've been trying over the years to see our epidemiology to predict what can happen and actually to assess our guidelines and our efforts in antimicrobial stewardship program. This is one example, I've been like a co-author in a couple of them. There is different rate of CRE, different pattern actually, what CRE is available in the Gulf countries. Multiple publication, try to look in the pattern, what kind of organism we have, so we can address the management. And it's the same currently with COVID-19. The other part of it is not only knowing what we have, is how to combat it, how to decrease those rates of MDRO. What happened with COVID-19, exactly the same, but I think we saw it in the shorter period when we were all busy in addressing the treatment of COVID-19 with all the medication, investigation, and under research. And we took, the antibiotic part as, yeah, we can give, that will not hurt the patient, but believe me, go to the basic, more antibiotic, longer duration, you will have the effect and you will see more MDRO. Just mention a couple of slides because, being part of a wonderful infectious disease working group among, the GCC, other country in the region. And we try actually to analyze, we did a survey to see how our physicians, whether they're infectious disease, ICU, chest physician who are dealing with MDRO, what there are challenges, external or internal, that face them to implement stewardship program, and what are the similarities and difference between the countries. We're trying to get some consensus so we can develop further recommendation. And in this slide, you see we get the response to the major elements of antimicrobial stewardship. Are we doing it very well? But we have a problem. And actually, this survey done last year, so I'm talking about COVID-19 pandemic, and you see that across the board, we have some strength and we have some weakness. So what's happened within the pandemic with the strain of the manpower and resources we have, actually, when you have weakness, whether it's stewardship or any program you have in your institution, probably that will be exposed, so that you will be exposed, and you will see that you have more problem in the weakness points. So we actually tackled in that analysis 5 important areas. It has to be very, very important and basic. We'll not go into the details, but believe me, they are essential: training and education, building capacity, infrastructure, enhancing regional research, and improving regional surveillance. And believe me, those were very important when we discussed this issue. But now, during the pandemic, we know that they were really very important, and more important at this stage than even before the pandemic. And part of this, part of this infectious disease group, actually, we have a collaboration with the British Society of Antimicrobial Therapy, and there's a course for antimicrobial stewardship program. You can probably register for it because it has been designed for our area, so you can really look at it up. One of the article that we work on it actually took almost 1.5 years to 2 years to really complete it, is management of those WHO critical priority gram-negative organism in Arabic countries of the Middle East. Really spend time, we try it, so we have the guidelines for surgical site infection, pneumonia, bloodstream, UTI. So it's really good to look for those guidelines, because really what's happening now with the pandemic COVID-19, we are overusing, and I'll show you the data, because all of us, I'm not saying our region only, the whole world is overusing the antibiotic. So sooner or later, we'll see the effect, which is a bad effect. And this is what one of the graphs in the article we have about the rate of different MDRO in our region. So when we go and tackle the specific topic of today's presentation, there are actually within the last, I can say 3 to 4 months, when we talk about COVID-19, we have to be very careful. The history of knowledge about it, we know it only for the last, we'll say from January, February, we started to get articles. Till now, we're talking about maximum of 9 months of knowledge. So still nothing really, we have it in details, and I'm sure all topics we discuss about COVID-19 will evolve in the future. So there are a couple of articles really looking and addressing the implication of having the coronavirus, COVID-19, and what it can do to the antimicrobial resistant pattern, and the prediction actually it will get it worse, and that's what we are seeing. So in this article, the second one, they address some mitigation strategy that you probably have to do in order to decrease the damage that can be done. So you have to look for short and long-term impact of COVID-19. You have to evaluate what you are doing in your institution, and I'll give you some hints from other articles. Actually, they have some nice recommendations. You have to have clinical treatment guidelines. So even if you have your COVID-19, please address the antibiotic. Don't leave it open. Don't leave it easy, because believe me, I'm sure most of you have dealt with cases, and they found it's very difficult sometimes to judge these cases. The organization, they have to do a better job in managing these cases, and even the diagnostic, and the rule of biomarkers, the rule of procalcitonin in making you just really help. It will not be a diagnostic, but it will help you in ruling out bacterial infection. And then the most important thing is at national level, there should be collaboration, because it depends on how you are dealing COVID-19 in your area. Like, for example, in our country, we have different facilities and we are moving patients. It depends on their criteria. If they have other complication, whether COVID-19 or non-COVID, to the hospital, which fit their clinical scenario. So we are moving patients a lot, and that's just move the MDRO with it. And so the guidelines should be unified across the institution. Primary care. I know that we've moved to telemedicine and moved, so that's probably give you more actually weakness in implementation of stewardship program. And then you have to educate the society, because most of us has to be apart, not the physician or nurses, working in the hospital, but a lot of people, they have to be home for a long time and probably approach pharmacy or, in the society sharing antibiotics. So that has to be emphasized. And as I said, coordination at national level is very crucial for solving the problem. I'll mention 2 actually slides. The WHO actually, they started, and I'm not saying, earlier, but within the last couple of months, talking about the importance of stewardship and addressing AMR in during the pandemic COVID-19. And this is here a quote from Hanan Balkhi, the Assistant Director General of AMR at WHO, which really emphasized to look into it and to follow up what's happening. This is second article, which really is talking about the silver lining between the COVID-19 pandemic that may be found where we are working with fighting the MDRO. And this is actually a quote from Carmen, and she actually leads the WHO Global Antimicrobial Resistance Surveillance Program. So that's where they are trying to address, because we know through our work with COVID-19, we are seeing it, and probably the situation is more difficult. We have patients that we sometimes, helpless, and we don't know what to do with them. So we say, yeah, probably it's okay idea to use more antibiotic. The patient, we're losing the patient. Why not till we are sure if it's bacterial or not? But we have to be careful. This article actually published in the Journal of Antimicrobial Chemotherapy. It's really, really very nice. And they are predicting the potential long-term impact of COVID-19 on the antimicrobial stewardship program. What's nice about it in this, you see in this table, actually, I'm showing you what's the affected area and what's the impact of it. Actually, some of the things that we do probably can decrease MDRO, and some of them can increase MDRO. I'll go just in several examples. Increase focus on hand hygiene. This is great because it helps in the reduction of AMR. Fantastic job. Social distancing, yes, it reduces it. Okay, less opportunity to isolate. This is because if you have really those surge of cases that all the countries in the world has faced, and when you have a facility can admit 100 patients, but you are running 40-50% occupancy, and all of a sudden in 2-3 days you have its full 100, the manpower, and not only 100 patients, they can be very critical patients. And how you deal with ICU cases, hundreds or even in tens, it varies. So that really make it difficult to cohort the patient, because you have enough institution for COVID-19 and they can be cohorted as COVID-19, but then you come like one patient having Acinetobacter, the other is Pseudomonas, and that sometimes is tricky within the facilities. The other example is a preemptive discharge of patient with and this is help, because if you want to speed up and you adjust your criteria for discharge earlier, that's much better than leaving them. But that will not be implemented in our ICU COVID-19 cases. And then, actually the PPE, please look at this. This is very important point, which is all PPE are used in the COVID-19, and I'm not talking about using it perfectly in this place. But you know what's happened is that when you cohort patient COVID-19, as a healthcare worker, we wear the full PPE. But really, sometimes we get weak in moving from one patient to implement the infection control measure, because we are in those full PPE. We think we are protected, but we may take one organism from one patient to the next bed with another MDRO. So keep this in mind. There are in this slide, there are other elements. Please, I think if you have time, go into them, because really they are really touch the reality we are working with COVID-19. This is another one, but this is a very important actually article that's really an eye-opener to what we are doing and how it can affect the MRO resistance. This is another beautiful article. Actually, it's called, the deadly trio. What are the deadly trio in COVID-19? I like the term. It's the COVID-19, bacterial co-infection, and the MR. Put three together, and we know that your MDRO in any case will increase your mortality. That's, not talking about COVID-19 mortality per se. Is there a case for co-infection? Yes, we know all our patients actually who are admitted COVID-19, they are high risk of having a co-infection, especially if they are colonized previously. So it can be different scenarios. Either the patient coming purely as viral COVID-19, then get superimposed colonization and then infection, or they are colonized already with MDRO. They have different stories and, prolonged history-free admission, and now COVID-19 coming in the top. So it's different case scenario, but the ultimate end may be the same. You'll see in COVID-19, especially the sick patient, reported that the median hospital stays 7 days, but I can reach 14 in our ICU, and I'm sure that's reported in the literature. It's beyond 10 days, talking about 2 to 3 weeks usually. Most of those patients who develop MDRO are ventilated, and with COVID-19 severe cases, we end up with intubation. Most of the cases, not, if not all of the cases. And then, the co-infection, if you see in this slide, we mentioned those three scenarios, but it's, scientifically, we're talking about that even colonization, we have this concept before, we know it before. So if you have any kind of viral illness, it actually enhances, and the colonization attachment of bacteria. So we all know about the viral or influenza when you get it, and then we talk about superimposed bacterial infection. So this is not new actually, but it's been actually mentioned in the COVID-19 that if you have the COVID-19, it helps to promote, the co-infection and superimpose, and it can change even the airway. It causes airway dysfunction. So it's there, and we'll see it. There is no out. And additionally, there's some talk that, even the type of interferon produces during the bacterial infection, if they have bacteria starts, it may facilitate the, COVID-19. And, this interferon and, all those cytokines and what we are talking about COVID-19 still play a role. I think we need more data about it in the future. This article also, it's really puts, what to expect, from superinfection and antimicrobial development. And, we need more prospective study. I know everybody is busy really seeing patients, but I think it's the time to collect your data and put it out there and try to analyze and probably look before the pandemic would happen, during the pandemic and post-pandemic, so you have a bigger picture. In this article, they mentioned couple, actually very interesting, because they mentioned what was published as infection, the rate of positive culture, and actually they mentioned also if you use steroid and the use of antibiotic. It's very clear that the rate of documented infection is much, much lower than the rate of utilization of antibiotics. So there's kind of discordance between our culture rate and the use. So most of it probably go with the concept of empiric, broad coverage without good evidence. So the stewardship, what we know. As I said, WHO really did a great job. And actually there's the talk about tackling antimicrobial resistance in COVID-19. There was an WHO interim guidance for the clinical management of COVID-19, and they actually insist in incorporating antimicrobial stewardship principle with specific recommendation if you are dealing. So please keep it at the back of your mind. And there were actually a couple of articles that mention what happened during COVID-19 that should really help you and in recognizing the seriousness of having COVID-19 plus MDRO, which will probably push your mortality higher. Just look at the right side of the slides, our experience. I can tell you that, yes, there is an increased use of empiric treatment because of the complexity of cases we have. We have efforts in antimicrobial stewardship taking place, but you have to keep in mind, I'm not sure what's happening in all the hospital, but I know that the teams, our manpower has been actually more deviated to deal with COVID-19. So even the stewardship program, we have to limit the number so we can. So there is some effect on the stewardship program. Infection control measure has been emphasized. It's a great job, but don't really forget the type that we said, that you are protected with full PPE, but to protect the patient, so don't transmit any organism from one to one. More immunocompromised we are seeing because those are at high risk COVID-19, those who will be admitted and have a higher mortality. We have prolonged length of stay for the ICU case because, most of them, as I said, 10 to 14 days. And we have a couple of outbreaks. So this is when you have outbreak, you have to deal, you have to be really meticulous in your infection control measures. We'll not go into details this. The IDs, actually in their clinical guidelines for treatment of COVID-19, they have a special section about antibacterial and antifungal. So what they have mentioned, first of all, they reported a couple of studies that was very clear. As I mentioned earlier, the rate of positive culture was really lower than how much we are using antibiotics. So the rate of positive bacteremia and culture, they're talking about 10% probably in average. But most of the patients, 60 to 70, they use empiric broad spectrum antibiotics. So we still have the same issue all over the place. So there is discordance between your infection rate and actual use of antibiotic. And they emphasize two important things, which also add up to the whole picture, is that most of our patients now, they are using steroids, which is immunosuppressive, and we know that probably increases the rate of infection. And actually our patient, most of them, they use biological agent like, tocilizumab or, others, which can modify even our immune system further and make us more susceptible to infection. There were a couple of reports about biologic agents. It may help to improve symptoms of COVID-19, but actually increase the rate secondary bacterial infection or sepsis. Actually, this article goes about antimicrobial stewardship that has core of COVID-19 response effort at the core. And this is very important. So you have to sustain it. And they mention a couple of benefits if you do an ASP program and develop it. So it helps you having strategy. It can help you in dealing with the guidelines, can help you in really optimizing the use of antibiotic. Actually, it's very good to be parallel to your efforts in COVID-19 and should be addressed seriously. So I'll not go into the details of this. There are a couple of actually of tables, and each element we know of the basic. Please remember the basics. So we talk about a prospective audit or education or IV to oral. They actually put the detail of it, how you can do it when you have COVID-19 cases. More about engagement of the lab and guidelines and clinical pathway, and actually nice details how you can go about it and make it better. So last article probably I go is really very, very nice with certain, like I think 12 recommendation. Do not neglect the antimicrobial stewardship principle. First of all, reserve it for the most severe presentation. And please make sure that the procalcitonin is not only part of the biomarkers for COVID-19. Use your imaging to see whether it's really a worsening of the patient because bacterial, or it's worsening because COVID-19 is getting worsening, or you have more infiltration because of fluid overload or heart failure. So that's, basic concept of antimicrobial stewardship. 2, if you start antibiotic, think about, what to start, okay? And don't broad spectrum, don't cover for atypical if you don't think so, atypical is a major issue. Then 3, reevaluate. We all the time talk about de-escalation, so you have to do it. Number 4, if it's continued, try to switch. So if I know that's bacterial, when to switch it to oral. So I know most of the ICU cases, ICU physician or chest, they'd like to maintain it till the patient gets better. There is no probably a good reassessment when to switch to oral. Number 5, antibiotic treatment should not exceed 5 days in most cases. But we know now, if you are working in ICU with COVID-19, you'll see that they are on antibiotic till the last day, discharge, or even if, there is a mortality. Number 6, if antibiotics are considered, beta-lactams is the best. So, try to avoid those, new broad spectrum antibiotic till the last. And, as I said, try to use the same pharmacokinetics, pharmacodynamics principle we talk about, which is, you use continuous administration. So, the beta-lactams antibiotic principle has to be done. Macrolides, quinolone, avoid it unless you have to, because all of us know most of our drugs we use COVID-19, they have interaction and they have cardiac toxicity. Plus, COVID-19 is well known to have a cardiac toxicity, so you don't want to add it. If you want to cover atypical, doxycycline will be your best choice. Number 7, use the standards. So if you have an ICU, please continue doing what you do. You have your bandits to prevent VAP, you have how to do it. All the elements, please go ahead and do it as much as you do before the COVID-19, continue the same dose. Azithromycin, I think there was a lot of talk about in the literature, so avoid it if you don't. It should not be a routine use of azithromycin in COVID-19. 9, antibiotics should not be given prophylactically. And this term of prophylaxis, to be very careful, because most of the patients admitted to the ICU, actually with bilateral pneumonia, they started from first day on antibiotics. So be careful with this term of a prophylaxis. Number 10, if during COVID-19 treatment a secondary worsening happen, please make sure it's bacterial. As I said, it's not COVID-19 deterioration, and it's not, other reason that can cause infiltration, like probably, heart failure, anything that probably can make the picture mixed, not clear. And finally, should be kept in your mind that during COVID-19 patient, COVID-19, the patient actually, they can have other infection. They can have UTI, they can have, whatever, cellulitis, we have cases of abscesses, because these patients are in the community and probably they have other problems before they have the COVID-19. And at 12, which is the last one, please be careful. National recommendation is a major issue. So finally, COVID-19 pandemic puts tremendous pressure on all healthcare workers, not least on infectious disease and infection control. So we really advocate that antimicrobial stewardship has to be implemented, promoted even more in this challenging time. And there are actually, one of the articles I show, there are a lot of research actually ideas, which I think it has to be taken into consideration. And when you plan for the future, it will be the best time to tackle this point where antimicrobial resistance and stewardship in COVID-19. There are a lot actually of information has been by the WHO, helps in really emphasizing antimicrobial stewardship in COVID-19. And I think with the whole thing, what happened with pandemic COVID-19, it really goes to the back. It's the you know, the clinical professional. We are physicians. We as physicians, it's very important to go to basics and knowledge of what we learn to implement to our patient. And here where we know that our physicians were really the essence, and you know, they were the basic for combating with the nursing and other allied health, the COVID-19 pandemic. So healthcare care will not realize its full potential unless make the change became intrinsic part of everyone's job, every day, all parts of the system. And stewardship is not an exception. It has to be there all the time. So set your target and your aim and work on it. Even if you start small, with one patient, one day, one admission, one clinician, that's the quality, and then you probably will succeed. Again, I repeat, whatever we know about COVID-19 is the tip of the iceberg. And I think we'll know more about it in the future. And thank you Team Bahrain. And I think I like this saying, if you want to go fast, go alone. But if you want to go far, go together. Thank you for listening. Thanks.
Thank you very much, Dr. Jamila, for this very interesting presentation. And please, if you don't mind, you can answer the question directed to you in the Q&A box right now, and stay with us. If there will be some time at the end of the session, we will be asking you some question live. Now, give me a great pleasure to introduce our last speaker in the first session today, Professor Richard Philip Dellinger. He is actually one of the major pillars who was with us from the beginning of our Emirates Critical Care Conference. He's a senior critical care physician at Cooper University Hospital. He is as well director of the Cooper Research Institute and designated institutional official of Human Research Protection Program, as well as the Animal Experimentation Program in USA. He will be talking to us about viral sepsis, what makes it different from bacterial and fungal. Professor Dellinger, the floor is yours.
Good morning from Camden, New Jersey, USA. I'm recording this, it's evening there. It's a great pleasure to once again be lecturing at the Emirates Critical Care meeting, and I'd like to thank Dr. Hussein Al-Rama and the organizers of the meeting for once again including me, this time virtually. Over the next 20 minutes, I'm going to be talking about viral sepsis, very hot topic now with COVID-19, what makes it different from bacterial and fungal sepsis. Well, as we know, sepsis is a dysregulated host response to infection. The host response, the immune response, is intended to help clear the microorganism from the body. And normally that's what it does, and we don't see much of it. But when it's dysregulated, we certainly do, and we see infection-induced organ dysfunction and later risks for secondary infections and apoptosis. So the dysregulated host response may be hyperinflammatory and hypercoagulable from systemic inflammatory response syndrome, or SIRS, which is very mild, tachycardia, white count changes, to, in some patients, cytokine storm with very high levels of pro-inflammatory and procoagulant mediators, with mild thrombocytopenia and minor elevation in INR in many cases, but disseminated intravascular coagulation in some. We now realize that there's a relative immunosuppression that occurs that typically does not manifest itself clinically, but may, with apoptosis-induced depletion of critical cellular components of the immune system, with increased T regulatory cells, increased myeloid-derived suppressor cells, and an immune suppression state. The microorganism has what we call pathogen-associated molecular patterns, or PAMPs. The host Typically, the macrophage has what's called pattern recognition receptors that recognize these PAMPs to initiate the host immune response. So this immune response it has a lot of similarities among bacterial, fungal, and viral infections, but it also has some key differences. The pattern associated molecular pattern molecules on the microorganism in bacteria are endotoxin or peptidoglycans. In fungi, typically one we talk about is beta glucans, and in viral infections it's double-stranded RNA. And then the host cells have pattern recognition receptors for bacteria, typically toll-like receptors for fungus, C-type lectin receptors, and for virus, retinoic acid inducible gene 1 or RIG1 receptors. Toll-like receptors, although predominantly considered to be a bacterial pattern recognition receptor, also are relevant to fungal and viral infection. So the immune response triggers release of pro-inflammatory cytokines from monocytes and macrophages. These pro-inflammatory cytokines produce acute phase proteins from the liver, such as C-reactive protein, which we have noted significantly present and often very high in COVID-19 viral sepsis. So with viral sepsis, the primary immune defense is called a type 1 response. It's interferon alpha and beta. Doesn't produce much of a pro-inflammatory response typically in viral infection. And that pro-inflammatory response tends to come primarily from phosphorylation of proteins instead of release of mediators from macrophages and monocytes. But in some viral sepsis, there's a type 2 hyperinflammatory response and may produce a picture indistinguishable from bacterial sepsis with organ dysfunction, cardiovascular dysfunction. We don't know exactly, we don't have positive proof of what drives that. It may be that the interferon alpha and beta are inactivated by the virus. We believe there's a shift to a predominant interferon gamma response, which is more monocyte macrophage mediator driven. And at least in some viral infections, it's noted that IL-18 may be a driver for this. Literature published with dengue, Epstein-Barr virus, and cytomegalovirus. So we know that you can see viral sepsis in Ebola. It may be a prominent, very prominent feature of some viruses, whereas other viruses, it's rarely seen. So Ebola is sort of the kingpin, MERS, CoV, SARS-CoV, SARS-CoV-2, or COVID-19. So COVID-19 deaths in my country, the US, since January 2020 is 247,000 and rapidly climbing this week with another big surge across most of the US. But even with traditional influenza like influenza A, the 2017-2018 flu season in the US had 80,000 deaths. So clearly, even with influenza A, based on the type of flu, the identity of that particular speciation of flu that year may be very deadly. And the 2009 pandemic of influenza A H1N1 was a particularly bad actor, with over 200,000 respiratory deaths internationally and over 83,000 cardiovascular deaths. Most of these deaths were in people younger than 65 years, which clearly distinguishes it from what we've seen to date with COVID-19. And 51% of these deaths occurred in Southeast Asia and Africa. Influenzal sepsis, we do see it every year. There are a few patients that come into the ICU with radiologic signs of lower respiratory tract disease, CNS involvement with encephalopathy, acute renal failure, and septic shock, but it's not typical. In that list of viral sepsis that I gave you, such as COVID-19, where we do see a lot of viral infection-induced organ dysfunction, the most prominent theory is that, like bacterial and fungal sepsis, this is driven by pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-1, interleukin-6, granulocyte colony stimulating factor, interferon gamma-induced protein 10, monocyte chemoattractant protein 1, and macrophage inflammatory protein 1 alpha. Now, I said that's the most prominent theory. There has been some literature published in both directions as to how prominent this pro-inflammatory response syndrome is. This is a publication this year that looked at plasma levels of interleukin-6 as a pro-inflammatory cytokine reported in COVID-19 compared with levels previously reported in ARDS in data sets that were available. And you can see up top is the COVID-19, and with COVID-19 severe deaths, severe disease, you really don't see a lot of IL-6 elevation here. Whereas with the some of the ARDSNet trials, now the PEDAL network it's called, you can see the IL-6 levels are much higher in the previous trials than what these investigators were seeing in COVID-19. And similarly here in another study, looking at a wide variety of pro-inflammatory mediators, you can see in yellow is the all-comers of COVID-19. In the purple or magenta are COVID ICU admissions. In the pinkish red is ARDS, and in the green is traditional sepsis. So the two box plots on the right are traditional ARDS and sepsis, and the purple magenta one is the severely ill COVIDs, and they're very similar. So this study shows they're very similar. So maybe what we're dealing with is sort of just traditional sepsis and not any special cytokine storm. Now, if there is a cytokine storm, some people believe it behaves in a similar fashion to what we see with things like beta hemolytic strep, toxic shock syndrome, and it may be more of a super antigen type occurrence. This is normal antigen processing where there's an antigen presenting cell that picks up the antigen and presents it to a major histocompatibility complex on the T cell, and initiates activation of some very small fraction of the available T cells, like 0.01%. Whereas with superantigen, it bypasses the antigen presenting cell and goes directly to the T cell receptor, leading to as high as 20% of T cells being activated, producing the quote cytokine storm of very high levels of pro-inflammatory cytokines, like you see in toxic shock syndrome with staph or with beta hemolytic strep. Now, one of the prominently studied and identified and discussed cytokine is the IL-6 pro-inflammatory cytokine. And the question is, how much of a role does it play in ARDS, multi-organ failure, and activation of coagulation? And as most of you are aware, we've seen a flurry of clinical trials published over the last 2 to 3 weeks, looking at IL-6 blockade. We've seen not only clinical trials, but also cohort data, observational data from patients with COVID-19 who received IL-6 blockade. And this data is very mixed. The predominance of the randomized clinical trials do not show benefit from IL-6 blockade. I will mention that the IL-6 blockade in the great majority of the clinical trials has been initiated in mild COVID-19 patients that require oxygen but are not requiring ventilation. Whereas some of the observational data looking at databases of patients that received IL-6 blockade or did not, there has been some association with the administration of IL-6 blockade and improved outcomes. So it remains controversial. At my institution, we tend not to use IL-6 blockade to treat COVID-19. Concerning the dysregulatory immune response, the immune suppression stage seen with the COVID-19 and other severe viral infections, there's a sustained and substantial reduction in peripheral lymphocytes, primarily the CD4 T cell and CD8 T cell, putting the patient at a risk for secondary bacterial infections. Now, whether this is a direct infection of lymphocytes by the virus or some other mechanism is not known. But with SARS-CoV, RNA was demonstrated in lymphocytes, has not been demonstrated in lymphocytes in COVID-19 to date, but SARS-CoV-2 RNA has been identified in the blood of COVID-19. So with viral sepsis such as COVID-19, you get activation of macrophages and neutrophils, dendritic cells, cytokine production, pro-inflammatory state, organ dysfunction, also cell death, apoptosis, especially of T cells. Now, when the counter anti-inflammatory response syndrome was first postulated, that was back in late 1990s, at the turn of the century. It was postulated that following the systemic inflammatory response syndrome, that there was a counter anti-inflammatory response syndrome that could arise and produce a hypo-inflammatory state nosocomial infection and late death. We now recognize that this counter anti-inflammatory response syndrome, this immune suppressive profile may actually coexist with the initial systemic inflammatory response syndrome. And I'll close by saying it's not as simple as bacterial versus fungal versus viral. It can be complicated, a secondary bacterial or fungal infection following bacterial sepsis, reactivation of a viral infection following bacterial sepsis, a bacterial infection following viral sepsis. This was very prominent in H1N1, and coexisting viral infections, either two viral infections, and we've seen influenza and COVID-19 here together. So in summary, we're still learning a lot about viral sepsis. Once again, we learned some with Ebola. We learned some with MERS. You know, we're learning a lot now with COVID-19. This is a opinion piece published earlier this year that I co-authored with John Marini and Dan Brody from New York. Brody's from New York, Dr. Marini from Minnesota. But we use the Indian parable of the 6 blind men and the elephant to describe what we thought we were seeing early in the pandemic before there was really a lot of good data. And I think we're still on the way to getting much better data, where with small data collections at one hospital or in one area, with just observational data, people were coming to conclusions about COVID-19 and sort of like they had the tail and they thought COVID-19 was like the tail, or they had the trunk and they thought it was like the trunk. But COVID-19 is many things and very complex. And in the end, how different COVID-19, ARDS, and sepsis will be from traditional ARDS and sepsis is yet to be fully defined. There are some aspects of COVID-19 that I think that will hold up over time as very unique. For example, the hypercoagulable state. So I'll stop here. I hope you found this information useful. And again, it was great to participate virtually in this meeting. Thank you.
Q&A box. Thank you very much, Professor Philip, for this informative presentation. And as I can see that most of the questions which has been submitted to the Q&A box already answered, so we can directly move to the next session.
Thank you very much, Dr. Ashraf. And now is our second session of the Emirates Critical Care Society. It's an honor for me to start this session. Finally, Dr. Hussain and his team, organizing team, scientific team, were able to get together and launch this hybrid conference. And it's a pleasure for me, and I'm really amazed at the amount of people that are at present on board. There are more than 50 countries, more than 1,000 participants that are attending this conference at present. So without much fail, I would like to introduce my first speaker. This speaker actually doesn't need any introduction. He's a very well-known figure all over the world, Dr. Jean-Louis Vincent. He is the professor of ICU in the University of Brussels, as well as a consultant. He is a lifetime award of, he's received actually several awards, in which one of them is the Lifetime Award of European Critical Society of Intensive Care Medicine, as well as the Achievement Award, Lifetime Achievement Award of the Society of Critical Care Medicine. He also received a College Medalist Award of American College of Chest Physicians, and the prestigious Belgian Award of Scientific achievements that he's done so far. But the best is that he's the editor-in-chief of the ICU Management and Practice, who intensivists like me, as well as intensivists all over the world, just love to go through it, to update themselves and to keep them going and knowing what is going on. So without much ado, Jean-Louis Vincent, I would like you to start your presentation. He will be talking about COVID-19. It is sepsis with multiple organ failure. Jean-Louis Vincent, without much ado, please go ahead.
Well, thank you very, very much. Thank you very much for such a kind introduction. It's my real pleasure to be here, although I would have preferred to be with you physically, but we all know what's going on and we have really no choice. So in the next 20 minutes, I'll basically speak about COVID-19 as a form of sepsis. And we actually took a while to acknowledge this. And when I say we, it's not really the ICU physicians. We identified it quite early, but the world in general. Sepsis, after all, is just a syndrome, like ARDS. And indeed, if you just indicate that the patient has sepsis, this does not have major implications because there is no specific therapy for sepsis in general. Antibiotics are for infection. The hemodynamic support, that's required in every patient who is with signs of altered tissue perfusion. But sepsis has no specific therapies. And we know that sepsis is very heterogeneous. It can occur in patients with pneumonia, with abdominal abscess, with community-acquired pneumonia, with various types of infections. So you may say that COVID-19 is more specific than sepsis because it is a disease. COVID-19 is the clearly defined infection. And yet it is still somewhat heterogeneous. Let's recognize it. Initially, people focused on the lungs. We thought that COVID-19 was really a lung infection. And people were referring to the PF ratio, the amount of PEEP required, etc. We were focusing on the lungs. What type of respiratory support do you use? Do you use volume controlled or pressure controlled? Could you put patients in a prone position even when they are not intubated? This was not new because before the era of COVID-19, we already saw some reports of prone positioning in non-intubated patients with severe respiratory disease. But of course, we described it again and again in patients with COVID-19. And this was probably helpful, especially in severe cases. The question was also when to intubate the trachea, because if it's too late, there is respiratory arrest, it's terrible. But if it's too early, perhaps it's not that good either. And there may be a lack of material, lack of personnel. I'll speak about it in my next presentation. So we learned that we needed to individualize the decision to intubate the trachea, not only on the basis of gas exchange, but also on the basis of clinical factors. What about the risks of SILI, of self-inflicted lung injury, when the patient breathes laboriously with large intrathoracic swings in pressures? That could be very bad for the lungs. So we need to look at the patient and decide on this particular patient, is it the right time to do it, or could we actually wait a little longer? And if the patient is intubated, should we use sedation and perhaps even paralysis? Not in all patients, okay? We would prefer to avoid these drugs whenever possible. At the beginning, these drugs were overused. There was actually a lack of muscle relaxants in some countries. In Belgium, it's still a bit borderline. But as a whole, we learned that mechanical ventilation was there just to support the patient with severe disease. But of course, it's not a treatment per se, it is support. So we should not intubate the trachea too early. And then we had these discussions. Are you sure it's only ARDS? Well, first of all, it was perhaps not at all ARDS, because according to our Berlin criteria, the patient must have been sick for less than 1 week, to speak about ARDS. Whereas here, usually they had been sick for longer than 1 week. But okay, that's semantics. But in terms of real lesions in the lungs, we could observe from chest CT scan that very often it's not bilateral edema. Very often it is localized infiltrates, which are usually ground glass opacities. So it's not only ARDS. There are different patterns we could recognize, and it's quite specific in a way. So this is actually notable that patients who are supposed to have ARDS very often had a relatively good thoracopulmonary compliance. The lungs were not so stiff. The airway pressures were not so high. And so we realized that by applying high PEEP levels, we could have been more deleterious than beneficial. So in view of these observations, lack of good relation between the degree of hypoxemia and lung mechanics, Professor Gattinoni proposed to speak about 2 types of COVID-19 related respiratory failure. The type 1 would be localized infiltrates. The type 2 would be more typical ARDS. And then with an Italian group, I had the pleasure to be involved. We reported that after all, when there is ARDS, it's not so different from ARDS due to other diseases. The patients may usually be more obese. The ARDS type may be more severe than in other patients, but there are no major differences there between COVID-19 related ARDS and other causes related to ARDS. But does it matter? Not really. We just wrote this piece, Professor Slutsky and I, it just came out 1 week ago. We said we have never seen a patient with ARDS, never, because we refer to the cause. And in the present time, we have the cause, it's COVID-19. So we should not look for a cause. So what does it change to say that your patient has ARDS? We must always limit tidal volume. Don't come with that. So what does it add to know that the patient has ARDS? Really nothing. We need to individualize therapy. There is no specific treatment of ARDS. Okay, now, what about the other organs? And then we started to realize that it's not just respiratory. It could be circulatory, and other organs may be also affected. It's not uncommon to see myocardial injury or actually shock, which could be of any of the 4 types. It could be hypovolemic, especially since at the beginning at least, people gave diuretics liberally, looking at the chest x-ray. Oh, there is water in the lungs, let's give diuretics. And then the other organs may show signs of altered perfusion because there is not enough volume, and patients died of that. It could be the heart, and it has been well demonstrated that acute cardiac injury can take place, and it's actually a potential cause of death. High troponin levels, major impairment of cardiac output, and thus oxygen delivery. We learned there is a problem of coagulopathy with pulmonary embolism that we may not suspect. We reported this paper where 1/3 of our patients had a pulmonary embolism discovered at time of the CT scan. We saw the clot in the pulmonary artery. And we know that sometimes this can result in obstructive shock, and it can be involved in the fatal outcome of some patients. And finally, there can be these distributive alterations with all these mediators. Some people spoke about cytokine storm. It's probably not a very good term, but in some patients, the cytokine levels in the blood can be found in very high levels. In some others, it's not so elevated. Again, we need personalization. But clearly, the sicker the patient, the higher the mediators levels. And very interestingly, in some patients with COVID, you can find endotoxin in the blood. Endotoxin, the virus, that's a gram-negative that gives endotoxin. Correct, yes. So perhaps these are endotoxins coming from the patient's guts, as there are alterations in gut blood flow. But there is, in this very nice paper published in Science, there is a nice relationship between the mediators levels in the blood and the endotoxin, the lipopolysaccharide, LPS levels in the blood. So it's a very complex process with neutrophil extracellular traps, with cell-free DNA being released. Very interesting stuff, but our time is limited today, so let's move on to go to the kidneys. Oliguria, increased creatinine concentration. Why? It's also a little bit special. It could be the decreased renal blood flow associated with the hemodynamic alterations I spoke about. It could be a direct viral cytotoxicity. There could be immunologic injury. There could be microthrombi, a microangiopathy. And finally, the brain. I think Professor Anand will speak about the brain after me. So I will quickly go through this. and mentioned that there are increased incidences of delirium, and there can be structural abnormalities like hematoma and intracranial hemorrhage or thrombotic events. Altered liver tests, yes, with sometimes also increased incidence of mesenteric infarction. We have got a couple of bad cases associated with the coagulopathy. The coagulopathy is important. It's not just a DIC, it's not just disseminated intravascular coagulation. The D-dimer levels are particularly elevated, but the PT, APTT platelet counts are not so abnormal. So perhaps we can call it the COVID-19 associated coagulopathy, or CAC. So there is an interaction between coagulopathy and the immune response. And this can account for the generalized problem in the body. We can find the virus in most organs of the body. We did an autopsy study, and others did as well, where we can find alterations in all organs. They are not very typical, but they are there. And the virus can be found in every single organ of the body. Very interesting. So yeah, we can speak about the viral sepsis. You know, when we speak about fever, altered white blood cell count, that's infection. When we speak about infection plus organ dysfunction, that's what we call sepsis. So when we wrote these recent guidelines, we mentioned sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection, but we didn't say it should be bacterial. It could be bacterial, viral. So let's be careful. Not all patients need antibiotics. Not all of them have a super infection. No, so we should not overuse antibiotics in COVID-19. Antibiotics will not help against the virus. And finally, in terms of implications, for a while, people focused too much on gas exchange and not enough on the other major components, determinants of oxygen delivery: hemoglobin and cardiac output. Giving diuretics just on the basis of a chest X-ray could be very bad. It may be very harmful. We should give diuretics only when the patient is very stable hemodynamically. But a number of patients with COVID will need fluids. Hypovolemia is as bad as hypervolemia. Not so much for the lungs, for the other organs. So that's how diuretics can decrease cardiac output, can be bad for the circulation and the organs in general. And we need to consider a fluid challenge technique where we evaluate the effect of a small amount of fluids. If there is no beneficial effect, we stop right away. If it's beneficial, good for the patient. And we may have to repeat it. Passive leg raising is fine. We can all do that. Very easy to do. But the question is, what do you measure? What do you measure when you do that? And there people don't do it right. It's not the blood pressure. No. You need to have a good monitoring system to evaluate a very transient increase in stroke volume during the test. It's not so easy. So that's how we still use primarily the fluid challenge, and we could use the butamine if needed to increase cardiac output when the patient does not respond to fluids. I realize my time is over, so I will reach the conclusion here. In terms of treatment, I will not speak about immunomodulation. Antiviral therapies are not very effective. Remdesivir maybe a little bit, but it's not highly effective. We should not forget the general support with anticoagulation, organ support, also nutrition. COVID-19, it is a form of sepsis with multiple organ failure, not just lung failure. And treatment should be personalized to give what the patient needs, not more, not less. Thank you.
Thank you very much, Professor Jean-Louis Vincent. It was a remarkable lecture, absolutely. I just loved it. And you're so true that it's not just the lungs that are affected, it's multi-organ. So without, let's go ahead with your next lecture, which is of course, very effective. Why? Just answer the question, why do some die? And why some survive? Please.
That's right. I went a little bit over time, so I will try to make it rather short, but you just introduced the topic very well. How come patients die of COVID-19? Because, you know, we know that in the ICU, maybe the mortality rate will be around 40%. If you look at the entire literature so far, that's what you will find. And the latest study coming from the Netherlands in the Lancet Respiratory Medicine indicates a mortality rate of about 35% in patients who need invasive mechanical ventilation. But if it's respiratory failure, well, we can use mechanical ventilation. And if it's not sufficient, we can use ECMO, extracorporeal membrane oxygenation. And if it's VA ECMO, veno-arterial ECMO, we don't need the heart. So the patient cannot die on pump. So that raises important questions. Oh, but the patient has renal failure. Well, we have renal replacement therapy. A patient should not die of renal failure. Oh, it's shock. Well, we have fluids, we have vasoactive agents, and perhaps diuretics again could be harmful, but usually shock is not that severe to induce death right away. Neurological complications are not so common, at least the serious ones, and they are not cause of death. Brain death is not a real cause of death in COVID-19. Pulmonary embolism, we mentioned that, bleeding associated with anticoagulation. These are problems, but patients should not die of this, or at least it should be a very rare cause of death. Multiple organ failure, yeah, that's probably the problem. And when we look at the various organs, we already mentioned how the heart may be involved, how pulmonary embolism could be involved, how there are different organ complications, but how does it account for the death of the patient? And my answer is here. This is a paper I wrote with Dr. Slutsky several months ago at the very beginning of the crisis. And we said, look, perhaps there is no room left in your ICU. Perhaps you do not have enough respirators. So you tried to expand your ICU. You tried to open ICU beds in the cardiac unit, in the operating room, in other places in the hospital. You tried to keep patients outside the ICU whenever possible, but there is a point where your ICU is full and there are more patients who must come in. Perhaps this did not occur in Dubai, in the United Arab Emirates, but in Europe, in Italy first, it occurred. And we have these discussions in Belgium, like in other countries at the present time. And the ethical principle is the principle of equity, of justice. We need to be fair to everybody. But there is also a question of proportionality of care. We don't want to do too much for elderly patients with comorbidities. These patients have very little chances of surviving the COVID-19. Now, if they are young enough, we could use mechanical ventilation and hope for the best. But if the patient is really elderly with comorbidities, it will not change the outcome. So perhaps we should not use invasive mechanical ventilation in some of these patients. This was reported in an English newspaper. A woman, 90 years old, dies from coronavirus after refusing a ventilator and telling doctors, I had a good life, keep this for the younger. So in many places, we had or we will have to address the issue of prioritization based on age, life expectancy, underlying illness, comorbidities. And perhaps we could use a score because we need to have a consistency in the decision and some transparency. People must understand why we decide this or that. In some centers, they like to use the SOFA score for this. In other centers, this is our center, we use a scale, a frailty scale. Here it's in French, but everybody knows the frailty scale, and we can add other factors, chronic organ failure, into a prognostic score that we could use. We would not decide only on the basis of a score, but this tells a little bit the hospital, the others, the emergency room people, where we are in terms of selectivity of admissions. We need to have a plan. We need to know what we have and where we go. We need to discuss it. We need to train people. We need to use video communication. We need to have a plan, because if we do not have a plan, then patients will receive the resources by random chance. Perhaps the first one who arrived will be the first one served. That's what we call the first come, first served basis, which is very bad, very bad. You should not penalize those who come later. So we need to have a plan, and hopefully with a plan, we could provide critical care services to more individuals with better outcomes. So it's important to have a committee for this. This is a recent publication on the US about the triage teams that always involve an ICU, well, a doctor, usually an ICU doctor, and they do not only involve a doctor. A nurse would be welcome, and they could be some other people involved. And this committee will reassess the situation regularly, and they will make some recommendations in terms of stewardship, triage criteria, conservation of resources, etc. They may not decide every day, because every day we need to have someone who takes the decision right there, physically at the entrance, in a way, of the ICU, evaluating the likelihood of achieving a benefit, the likely duration of the benefit, the quality of the benefit, and the resources needed for this. You know, the discussion goes for ECMO as well. This is the recent report from a large registry indicating that indeed maybe about 40% of patients treated by ECMO may survive because these patients were selected, of course. So yeah, we are doing the right thing there. But you know, when we decide to start an ECMO, we may actually not only use the machine available, that may no longer be available for someone else, but they may also impair, alter the care of the patient who is in the next bed, because the nurses and the personnel will be more busy with the ECMO, and they may have less time for the other patients. We need to think about it. That's why we wrote this editorial. First come, first served basis is bad. We need to make sure that other patients will come in as well and will have the same chances. You know, in Italy at the beginning, sometimes the ICU doctor would not allow any non-COVID patient in the ICU, telling his or her colleagues, oh, it's impossible, you know, we don't know where to put the COVID-19 patients, and now you come with another patient who is not a COVID-19 patient. Of course, there are patients who could still be traumatized, or could have a peritonitis, or could have another bad problem. Yes, we need to treat the non-COVID-19 patients as well as the others. And when the ICU is full, once again, I insist, we cannot say, sorry, the ICU is full, what can I do? That's something we may do when we need to transplant kidneys. But otherwise, we need to do something about the whole system. Lottery cannot be used either. A lottery would be used when there is one bed and two identical patients coming in. We would say, okay, one patient may occupy the bed, the other patient will not. Actually, the situation is more like this. You have perhaps one empty bed, but you have a number of patients coming in. So perhaps you may have to discharge one or two or three patients, maybe allowing them to die peacefully, to have a bed for someone else, having reasonable chances of recovering. It's tough, very difficult, but sometimes we need some ethical decisions, and this is really tough. So we need to discuss it very openly, and we need to consider that if there is no respirator available, we may actually consider stopping the respirator for someone who is just about to die. And if you are a very religious person, you will understand that Allah or God or whoever has already decided to take the patient away. So all of these are difficult decisions. We need to have senior staff members helping the junior ones. We should not leave this junior person alone. Remember this New York physician who committed suicide after a day in this nightmare in a New York hospital. So that's how I wrote this piece in the Lancet about how many patients die from COVID. Some die not even reaching the hospital because we think it's not worthwhile. They could die at home. Could be reasonable. Or they arrive in the hospital, but we would not intubate the trachea because it would be too much. Or if the patient deteriorates on mechanical ventilation, we may decide not to use ECMO because that would be futile therapy. We should not do that. So it's important when we look at the number of deaths from COVID-19. What is the cause of death? Some people die of their underlying disease. This skydiver who forgot his parachute died of coronavirus because he was tested positive. Is it a COVID-19 death? So if we look at a patient in a nursing home, elderly, dementia, and the patient died, is it a COVID-19 related death or not? In Belgium, we had, as you may know, major questions about this because we had many, many, many deaths of COVID-19 in homes, in nursing homes. But we fear that in some cases, the general practitioner attributed the death to COVID-19 when actually it was not necessarily the case. So let's move on to reach. I'm not saying that there is no over mortality. That would be ridiculous. No, 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 no. In Belgium, you can see there was a substantial increase in mortality during our first wave last March, April. But it's interesting to see that there are less diagnoses of cancer during that time. So patients with cancer may actually die a bit later because of the cancer which was not treated, because they were too afraid to go to the hospital or to their doctor. In the US, same reports of over mortality. Undoubtedly, this is the case. So when someone dies, I think we need to think about it. It's not that there is right or wrong. It's just difficult to know, did this patient die really of COVID-19? Or did this patient die of the underlying cancer? Or the advanced dementia? Or the advanced cardiac failure, etc. So these are difficult questions. We need to support our personnel, and we need some psychological support for the people who work in the ICU. We have fantastic teams, and we need to help them because sometimes they live very, very difficult experiences, but hopefully the team is there. We are all together to fight against this bad virus. Thank you very much.
Thank you very much, Professor. I think we are undergoing the same circumstances as you are. But we have some common grounds in this. We are suffering and undergoing the same circumstances as you are. Thank you very much for sharing your expertise on this. And there is a question and answer box. I would like you to review it and see if you can answer it while you're on it. And it would be a pleasure if you stay on till the end of the session to answer more questions. Thank you very much. It was a pleasure and an honor for being here with you, even if it was virtually. I would like to hand over the session to Dr. Ashraf Al-Hufi, and he will continue the session.
It now gives me a great pleasure to introduce our second speaker. And as we all know, he's very well known in our area. He's one of the pillars of our Emirates Critical Care Conference since we started, Professor Jilali Anan. He is the chief of the general ICU in Raymond Poincaré Hospital, as well as the dean of the Faculty of Health Science, University of Paris, professor in medicine in Garches, France. He will be talking to us about his favorite topic, corticosteroids, but this time for COVID-19. Professor Jilali, the floor is yours.
almost 1 year now. And dear colleagues, it's a great pleasure to be with you today and to deliver you a talk about how to use corticosteroids for patients with COVID-19. So as you know, we are facing for almost 1 year now an unprecedented pandemic. At the time I prepared the slides, so almost 1 month ago, there were about 36 million people in the world that were concerned by COVID-19. And now, 1 month later, we are close to 60 million people. And the mortality rates have increased by at least 300,000 additional deaths in a single month. So it's really something that we never have seen before and is really causing many troubles to all the countries around the world. Among the treatment for COVID-19, for sure corticosteroids is the one for which we have the most evidence. So first, let's talk about the rationale. So COVID-19 related to a severe acute respiratory syndrome, coronavirus 2, is contrary to MERS-CoV-2 or to SRAS, is more than just an infection, is a sepsis due to a virus. And indeed, if one goes back to the current definition of sepsis, sepsis 3 definition, requires an infection, requires at least a SOFA score above 2, with organ dysfunctions related to this infection to call this sepsis. And actually, SARS-CoV-2 and COVID-19 is an infection because you have pneumonia related to SARS-CoV-2, also resulting in a number of cases of organ dysfunctions with the lung as the primary organ to fail, but there are in a substantial number of patients, coagulation disorders, in 1 out of 3 patients, shock, and in one out of 10 patients, roughly, acute kidney injury. So no doubt that SARS-CoV-2 is causing either a huge number of patients sepsis and septic shock. And one can see here that we know now very clearly what is the natural course of a disease. And we know that it takes about a week or so from contamination to onset of severe symptoms requiring patients' admission to the hospital. And the acute respiratory distress symptom and other organ dysfunction usually occur around the 8th to 10th day following the viral contamination. In most of cases, fortunately, the host response will be able, by mounting an appropriate and coordinated monocyte responses, in appropriate induction of interferon pathway, activation of ASCs and seroconversion, and that will help the body maintaining homeostasis and preventing severe cases of COVID-19. In about 1 out of 7 to 1 out of 10 patients infected by SARS-CoV-2, unfortunately, the host response will be deregulated with endothelial injuries, activation of a coagulation system, overactivation of pro-inflammatory mediators, and a deregulation of circulating monocytes, resulting in systemic overwhelming inflammation, resulting in organs failure and eventually in death. And indeed, there are many papers now nicely demonstrating that there is a proportion or linear relationship between the amount of inflammatory mediators circulating in the blood and the severity of illness, as demonstrated here with 4 groups of patients: asymptomatic patients, pauci-symptomatic patients, severe pneumonia, and patients with ARDS. And one can see in the red colors that in these patients with ARDS, there is definitely very high circulating levels of most of the inflammatory mediators. And what is also known now is that the main factor that drives from paucisymptomatic or mild disease toward a severe disease is the transformation of an epithelial disease, where only the epithelium is injured by the virus and the inflammatory response, to an endothelial disease, where beyond disruption of epithelium, there is severe injuries to the endothelium in the whole body. So basically, and in summary, when SARS-CoV-2 infected a man, then there is roughly two stages of the disease. The first one is the replication phase that lasts 4 to 7 days, during which the virus replicates strongly in the body. And during that phase, there is no rationale for using agents. And then there is a second phase that drives the severity of illness that is characterized by overwhelming systemic inflammatory response, leading to organ dysfunction and death. And during that phase, corticosteroids may be a valuable treatment to downregulate, to attenuate this inflammatory cascade. And as you know, as these patients cared in our unit, again, COVID-19 is most often sepsis and septic shock, with the patients requiring renal replacement therapy, vasopressor therapy, requiring high PEEP and high oxygen delivery, proning position, and most often, and very often, ECMO support. So a sepsis is not just a lung infection. And we know that corticosteroids are very powerful in regulating the immune response. When there is a break in the epithelium, for example, caused by SARS-CoV-2, the danger-associated molecular patterns that are released by the cells debris will activate the resident cells in the tissue, and these resident cells in the tissue within minutes will release a number of mediators that aim at promoting inflammatory responses. At this time, as early as within minutes, corticosteroids are also released in this tissue to downregulate the release of pro-inflammatory chemokines and other molecules. Following hours after the break of the epithelium, then corticosteroids continues to downregulate the inflammatory process by downregulating the transmigration of circulating cells toward the tissues, by inhibiting the integrins, E-selectin, and also by attenuating the tethering, rolling, and transmigration of circulating cells toward the tissues. Then, after days, when it's time to make an end to the inflammatory response, corticosteroids will reprogram the resident cells toward increased phagocytosis to help cleaning the tissues from apoptotic neutrophils and other cells debris, and will also promote the release of anti-inflammatory mediators like IL-10 and TGF-beta that will inactivate circulating inflammatory cells. And finally, when it's time to heal the tissue, corticosteroids will then downregulate the healing process to avoid too much epithelization, to avoid too much collagen deposition, and to avoid too much angiogenesis. At the cells level, as you know, the dendritic cells is the main target for corticosteroids, and the dendritic cells is actually presenting antigens to CD4 T cells. And again, all the molecules that are expressed by dendritic cells to activate the T cells and the CD4 T cells will be inhibited by the glucocorticoid. At the level of the CD4 T cells themselves, glucocorticoid will block all nuclear factors like NF-kappa B or AP1 or FN-FAT, and then again preventing the activation of these CD4 T cells. In lymphocytes, glucocorticoids will reprogram the cells toward anti-inflammatory profile by stimulating Th2 cells polarization, Treg cells polarization, and by inhibiting the polarization toward Th1 or Th17 cells. So at the bedside, the evidence, as highlighted by the Cochrane collaboration early in January this year, there is enough evidence in sepsis, both in children and adults, to highlight that corticosteroids are able to stimulate favorable outcomes in patients with sepsis. So what about COVID-19? We have now several randomized controlled trials that have been released. The first one to be released was a platform trial recovery, which have a domain investigating 6 milligrams per day of dexamethasone for 10 days in patients hospitalized with COVID-19. That trial was stopped prematurely because it was associated with a remarkable improvement in survival. The 28-day mortality dropped down in the dexamethasone treated patients compared to usual care in a remarkable manner, with 17% of relative risk reduction of dying at 1 month, and also any of the secondary outcomes were improved by the corticosteroid treatment. This was true for the whole population, and when looking at patients according to respiratory support, clearly patients who required oxygen, either with or without non-invasive mechanical ventilation, and those who required invasive mechanical ventilation, whereas those patients who did not require oxygen did not draw a survival benefit from that treatment. There are other trials. The REMAP-CAP international platform has investigated hydrocortisone, and in that trial, basically, the primary outcome was a combined outcome of organ support 3 days at 3 weeks. And one can see, if one focused on the right-hand side graph, where there is 3 groups of patients on the top, usual care in the middle, hydrocortisone only when there is shock, and in the bottom, hydrocortisone for 7 days at a fixed dose. And the color code, more red, indicates less organ support 3 days. Blue color indicates more organ support 3 days. So it's obvious here that corticosteroids and hydrocortisone was associated with a remarkable improvement in outcome in that trial that enrolled more than 400 patients in the ICU. This is the numbers of a primary outcome in this study, and there was also another independent trial in France of hydrocortisone compared to placebo in a double-blind manner that also randomized close to 150 patients before being stopped prematurely following the release of recovery results. And again, in that trial, the primary outcome was a composite outcome assessed at 3 weeks. And again, there was also not statistically significant due to the sample size. The outcome was improved by almost 10 points in the hydrocortisone treated group compared to the placebo group. And we have been part of the task-active meta-analysis of all randomized controlled trials published in JAMA in September 2. And one can see that we were able to collect data from 7 RCTs. And what we found basically is that the overall effects, the white diamond in the bottom, showed a substantial improvement in survival at 1 month in patients treated with corticosteroids compared to usual care or placebo. We found no evidence for difference in treatment response between dexamethasone, hydrocortisone, or methylprednisolone, we also found no evidence for difference in treatment response according to mechanical ventilation, according to the use of vasoactive agents, according to gender, or according to age. And finally, also according to the dose of corticosteroids, low versus high dose. So in conclusion, the deregulated immune response to SARS-CoV-2 drives lethality in COVID-19 patients, just like in patients with bacterial sepsis. Corticosteroids have been proven to favorably modulate the immune response in sepsis, and data from 7 RCTs found that in patients with severe COVID-19, corticosteroids probably reduce mortality, probably do not cause serious adverse events. Effects are probably independent from age, gender, duration of disease, the type of corticosteroids, and the dose of corticosteroids. And this is now why WHO recommends corticosteroids, either dexamethasone or hydrocortisone or methylprednisolone at a low dose equivalent of 6 milligrams per day of dexamethasone in patients with COVID-19 who requires oxygen therapy. Thank you very much for your attention.
Thank you very much, Professor Jalali, for this interesting presentation. And we are now going for the next presentation. The next presentation will be also by Professor Jalali Anand, and it will be about the neurological involvement in COVID-19.
This time, my task is to discuss a little bit about neurological involvement in patients with COVID-19. So once again, we are facing an unprecedented pandemic related to a coronavirus, SARS-CoV-2, causing the COVID-19 disease. We are now close to 60 million people dying as having the COVID-19 disease, and close to 1,500,000 patients who are dying or who died from COVID-19. So, as you know, the clinical features is not only lung involvement. So there are different categories of mild disease, which correspond to approximately 80% of cases. A severe disease, meaning that the patient has symptoms of dyspnea, hypoxemia, and involvement of the lung at imaging of chest imaging for 50% or more, and the critical disease when there is respiratory failure or other organ dysfunction, and has been reported in roughly 5% of cases. So the clinical presentation of patients with COVID-19 beyond the flu signs, fever, headache, cough, myalgia, patients have evidence of more severe lung involvement with shortness of breath and potentially other organ dysfunction and in some patients, diarrhea and abdominal pain may be observed. There are now a bunch of evidence that the nervous system can be involved in patients with COVID-19. And both the central nervous system with encephalopathy or encephalitis, viral encephalitis, that means documented of the virus in the brain, viral meningitis, stroke, or peripheral disorders like anosmia, ageusia, as well as some form of Guillain-Barré syndrome have been reported to be related to SARS-CoV-2. So we have reported severe neurological involvement in 10 patients with out of 60 patients with COVID-19 related acute respiratory distress syndrome requiring invasive mechanical ventilation in the ICU. And what we found is about 1 out of 5 patients had coma, not explained by other problems than COVID-19. Many patients presented with cranial nerves paralysis. In some cases, we had severe agitation with delirium. Some patients had abnormal movement like non-epileptic myoclonia, and almost all the patients presented with corticospinal tract signs. And there were also evidence of spinal bulb involvement with quadriplegia, as well as Guillain-Barré syndrome. When we looked at the cerebrospinal fluid, what we found is mild to moderate increase in protein levels. We never found meningitis, and PCR testing of the cerebrospinal fluid was negative in all patients. Brain imaging was systematically performed in these patients, and we had observed a number of lesions. Like, for example, here, that was, we reported this in neurology a couple of weeks ago, of the lesions demonstrating the cytotoxic effects of COVID-19 within the corpus callosum, that one can see here with abnormal restricted diffusion and this bright signal here. So that cause that is really typical of direct cytotoxicity of either virus or inflammatory cytokines. Very often, we observe in almost all cases at MRI hyperintensities within the olfactory bulb, as shown by the white arrow in the A panel on sagittal view, as well as on coronal view, again shown by the black star and the 2 white arrows. And also in the C panel, one can see the involvement of cranial nerves shown by the white arrows of both the oculomotor third cranial nerves and the left trigeminal fifth cranial nerve. Again, so the brain and cervical spinal cord here of MRI in a 25-year-old woman with no previous disease and who presented with almost no respiratory signs and was positive for times, and she presented with rapidly progressive weakness and numbness of the limbs and vomiting. And the MRI images reveal a longitudinal extensive transverse myelitis of the medulla oblongata and cervical spinal cord. You can see there's a dotted white arrows, minimally expansile and hyperintense. The lesion spans the entire cross-sectional area of the spinal cord. And hyperintensity of the olfactory bulb, white arrows, and hyperintensity of the olfactory mucosa as well. So this is a very rare situation where the main complication of COVID-19 was severe neurological involvement with quadriplegia in a very young woman. What I can tell you is now this patient has fully recovered. She has clinically no more neurological signs 3 months later and has resumed her previous social and professional activities. We also performed a number of autopsy examinations to these patients, and including brain examination. So other studies have shown that there is mainly hypoxic ischemic injuries with neuronal loss and the presence of red particles. as shown here in different parts of the brain, the frontal lobe, the hippocampus, the cerebellum, with arteriosclerosis in these patients, but also microglial nodule and perivascular inflammation. What we found is, again, a strong inflammation within the brain with perivascular lymphocytic inflammatory cells and infiltrate within the hypothalamus. Where we found CD3 positive T cells in the splenium area and CD68 cells highlighting associated perivascular macrophages and moderated microglial activation, suggesting or supporting brain inflammation in these patients with COVID-19. We also found more striking lesions as shown here. At gross examination, one can see a right frontal hemorrhage, large hemorrhage, and also a small mesencephalon infarction in the same patient. We looked at the expression of angiotensin-converting enzyme 2 receptors within the endothelial neighboring the neurons, and found not in all patients, but in about 1 out of 4 patients, strong expression of ACE2 endothelial receptors, which, as you know, are doors for the virus to enter into the cells and in particular into the neurons. At the electron microscopy, we were able to show rare small particles highlighted by the red arrow here, evoking the coronavirus particle in a lytic background, and the lytic background was related to the post-mortem delay. But we could find only in 1 patient, so that evidence of direct presence of the virus within the neurons. So in conclusion, neurological complications may occur in about 15 to 70% of cases of COVID-19. It's important for clinicians to perform careful neurological examination because of the prognosis value of CNS involvement. Whenever needed, imaging, and in particular magnetic resonance imaging of the brain, should be performed to detect the central nervous system involvement. And again, this may have strong prognostic implication. SARS-CoV-2 may occasionally cause direct neurocytotoxic effects after penetrating the brain within the olfactory bulb and propagating deeper towards the brainstem. Most often, COVID-19 is similar to what is seen in bacterial sepsis. Thank you very much for your attention.
Thank you, Professor Jilali, for this nice presentation.
Hi, good evening, everybody. Welcome again to our first hybrid virtual Emirates Critical Care conference. And I would like to introduce our first speaker for the last session for today, my colleague, Dr. Ashraf Al-Houfi. He is a consultant ICU in Dubai Hospital, examiner for the Royal College of Physicians, UK, professor of medicine, Dubai Medical College, and he is the chairman of Infection Control Committee, Dubai Hospital. His topic will be about COVID-19 pandemic infection control dilemma. Dr. Ashraf Al-Houfi, the floor is yours.
Bismillah ar-Rahman ar-Rahim. And thank you very much for the warm introduction. In the next 20 minutes, I will be talking to you about some of the dilemmas which we faced during the period or the peak of the first wave of the COVID pandemic. And I think you all will agree with me that the COVID pandemic did seriously challenge the healthcare system. It challenged it from all aspects. Actually, it put a dilemma on the physicians in a lots of aspects: diagnostics, therapeutics, ethics. But today, I will be focusing more on some of the infection control dilemmas. In January, when we thought that there is a storm coming from Far East, we tried to be prepared. We said, we're trying to take some measures to control the infection from spreading. And then instead of being scared, we tried to be prepared. So we tried to take all the actions which normally an infection control team will do. We give lectures about coronavirus. We updated our infection control measures. We put a protocol what to do when we face cases. We even did a drill about high influx of cases, but by that time we were only talking about 20 to 25 cases. We never thought that we will be dealing with a problem with that magnitude. We're talking about 50 million. We're talking about 1.5 million deaths. We're talking about more than 150,000 cases here in UAE. So the challenge was real, and it was really difficult time. During this difficult time, we have to do a lots of desperate measures and drastic changes in order to accommodate and deal with this pandemic, like evacuating wards, like stopping an outpatient services, like stopping all the elective services. We have to modify the design of our hospital in order to be able to accommodate the large number of cases which is coming to us. We have to create a COVID-compatible wards because we need to create a lots of beds which has the ability to be a negative pressure ventilation rooms. We have to extend our ICU. Dubai Hospital, for example, has a 20-bed ICU capacity, and we have to understand that we have to increase it to over 100-bed capacity in order to deal with this overwhelming pandemic. The problem was that from where you will be able to cover all those beds with trained doctors and nurses. The impact of COVID-19 was very clear. There was a very large number of patients coming to the hospital. A large number of them need to be admitted because of close observation. A large number of them need to be admitted to the hospital and to the intensive care unit, got intubated, mechanically ventilated, and they are staying in the hospital for quite some time. Some of them are having a long stay in the hospital with tracheostomy, whether they are ventilator dependent or not dependent. That poses a serious risk to the patient safety issue, because all about the healthcare is about the patient safety. We all know this statement about patient safety. First, do no harm. Everybody is aware about this statement, because simply any patient coming to a healthcare facility, he is hoping that he will get better. At least, if we are not able to make him better, his condition should not neither become worse or he should have any harm. And it's very well known in all healthcare services that there is no patient safety without proper infection control. The enemy of infection control, as we all know, is lack of personnel. So shortage of staff, lack of time, so overcrowding, lack of supplies, and lack of knowledge and training. And if you ask yourself where you will see those four enemies in front of you, you will see them during the pandemic, because this is how our healthcare service have been challenged. We encounter a lots of problems related to infection control during that first wave of pandemic. We noticed that there is a significant increase in the rates of HAI, the hospital-acquired infection, particularly VAP, ventilator-associated pneumonia, CLABSI, catheter-related bloodstream infection, CAUTI, a catheter-related urinary tract infection, in addition to significant increase in the number of multi-drug resistant organisms causing infections, and this will result in a high impact on the morbidity and mortality, and definitely will have a serious blow to the concept of patient safety, which I just mentioned. If you ask yourself, if you are trying to prevent a hospital-acquired infection, what usually you need? You need simply enough number of trained nursing staff and implementation of a proper care bundle. If you stick to those parameters, you will be able to decrease the rate of HAI, hospital-acquired infection, and device-related infection like VAP, CLABSI, and CAUTI. In Dubai Hospital, we have a very good, very well implemented, very well established ventilator bundle. And we are doing that for over a decade now. And it is very effective in reducing the incidence of VAP in our facility. But look at what happened to us. When you are having a lack of trained nurses, when you are having a low nurse-to-patient ratio, and you are having problems in implementing the elements and components of the bundle itself, ask yourself, in the COVID-19, when everybody is scared about transmitting the infection, about an aerosol generating procedures, how we will be able to convince our nursing staff from the safety point of view that they will be able to safely implement the mouth care, the subglottic suction, the cuff pressure measurement, and the condensate drainage as part of the ventilator bundle. We are telling to them, try to avoid the aerosol generating procedures, and at the same time, we are trying to convince them to continue producing aerosol generation while they are trying to implement the components of the bundle. Yes, we are trying to reduce that by using a closed suction catheters, but remember, even using the closed suction catheters exhausted our supplies very early. And why is that? Because normally, in normal days of practice, you may have 1 or 2 patients in your 20-bed ICU who might need a closed suction catheter. But if you have 100 patients, all of them are requiring a closed suction catheter, you will exhaust your 1-year supply in a week time. We try even to improvise by asking the nurses, if they are trying to collect samples from the endotracheal tube, to switch off the ventilator at the end of expiration and clamp the endotracheal tube, hoping that this will decrease the aerosol generation while we are collecting the sample from the endotracheal tube. Ask yourself what will happen when you are asking your nursing staff and your doctors to help in proning. Proning a patient requires 5 to 6 nurses and 1 doctor. In the normal daily practice of ICU, we may need to prone 1 patient, and we consider this as a heavy work. During the pandemic, there was 5 to 6 patients to be proned. Another 5 to 6 need to be deproned. You can ask yourself from where you will get enough staff and elaborate them for enough time to do this exhaustive procedure. That will take the nurses out of their usual care. And as I mentioned before, the enemy of infection control is understaffing and lack of time. And then ask yourself again, during proning a patient, how the nurses will be able to maintain the ventilator bundle, how they will do the mouth care, how they will do the subglottic suction. It is the proning which is actually an important method of treating our patients during the COVID pandemic, was preventing our nurses from doing and improperly implementing the ventilator bundle. What about the sedation break, which is actually an essential component of our ventilator bundle? We know that you need to make a sedation break in order to assess the ability of weaning the patient off the ventilator. Now, if the patient is still COVID positive and you make a sedation break, they are becoming irritable. You risk self-extubation and emergency re-intubation, and you surf injuries. All of this are aerosol generating procedure. So the constant practice was to heavily sedate most of our patients for a longer time, as long as they are COVID positive, in trying to reduce the aerosol generating procedures, which might result from the sedation break. The prolonged sedation resulted in muscle weakness, ventilator dependency, and a lots of patients in need for tracheostomy. And when you have too many patients with tracheostomy, ventilator dependent or ventilator not dependent, you are risking a colonization with multi-drug resistant organism to their airways, which will increase the problem when this will cause infection. The same happens in the central line bundle. We do have a well-established central line bundle, which was very effective. The same problem happened during the COVID pandemic. Patients are staying in the ICU for a longer time. Patients are hemodynamically unstable, and a need for central line to stay in place for a longer time because we need to give a lots of pressor support. Not to mention the coagulopathy, with the patients having impaired coagulation parameter and thrombocytopenia. So everybody is trying to avoid bleeding by going to the femoral axis. And we know that the femoral axis is an invitation for infection because the infection rate in femoral axis is much higher than the internal jugular and the subclavian line. Too many patients were having acute kidney injury requiring dialysis and CVVHD. And this means you need an extra access for the dialysis. And the more access you have, the more likely you will develop access-related infection. Not to mention the immune suppression, which usually happen in those patients, whether it is related to the COVID itself or related to the medication which we give in treating COVID, like the steroids or the tocilizumab. The end result is significant likelihood of developing device-related infection, whether it is VAP or CLABSI or CAUTI. It is the same problem. The end result is significant increase way above our benchmarking during the COVID pandemic. And all those infections are increasing the likelihood that the patient will have infection-related sepsis. And as we know, sepsis is usually associated with multiple organ dysfunction. And the multi-organ dysfunction is associated with significant morbidity and mortality, which is a serious blow to the primary concept of patient safety. It's not because we are not willing to do it, it's because we were not able to do it because of the COVID pandemic. The second part which I want to mention during this presentation was related to the antibiotic usage and antibiotic stewardship. Probably you heard a wonderful lecture earlier about the antibiotic stewardship problem which we are facing during the pandemic. The guidelines have told us that mechanically ventilated patients, because of severe COVID pneumonia, can be started empirically on antibiotics. That was the guidelines which mentioned this statement. The problem is, everybody admitted to the hospital who even require any kind of oxygen support was started empirically on antibiotic, regardless to the evidence of bacterial infection, regardless to the result of the bacterial cultures or results of the bacterial markers. And this will result in an overuse to the antibiotic. Regardless to what you will see in the culture or the biomarker, we did not see any kind of discontinuation of this antibiotic. And the constant question is, we are afraid because the co-infection and the super infection by bacteria on the COVID-19 pneumonia is quite high. And if we don't start an antibiotic, we may risk that this patient might deteriorate. Actually, most of the studies reviewed the meta-analysis, which is being conducted during the last few months, have proved that the co-infection, this means the presence of bacterial infection at the time the COVID pneumonia is presenting to the hospital, is actually quite low. Maybe in 7, 10 days, 14 days later on, the incidence of super infection of those patients who are already on the ventilator with multiple lines in multi-organ failure become a little higher. So I collected for you some of the studies and the reviews which showed very clearly that a co-infection at the time of COVID pneumonia presentation of bacterial origin is very low. It's actually less than 3%. And when the patients stay for a longer time in the intensive care unit on the ventilator, it may rise between 10 to 14%. But unfortunately, between 70 to 80% of patients are already started on antibiotic. So in your best estimate, the super infection at day 10 to 14 is 10 to 14%, yet 80% of patients are already on antibiotics. So what was the conclusion of all those meta-analyses? Despite the incidence of bacterial co-infection and super infection was low, most of the patients have been started on prolonged courses of broad-spectrum antibiotic, and they are always escalated. So the patients is never in the mood of de-escalation or stopping antibiotic, no matter what will happen. So majority of our COVID patients, if not all, did receive some courses of third generation cephalosporin like cefotriaxone and Zestromax between 3 to 5 days. And then they feel that the X-ray is not improving. They change it to peptazo plus either fluoroquinolone or an aminoglycoside. And in 2 to 3 days, that patient will automatically go to a carbapenem plus a vancomycin or a teicoplanin, regardless to the bacterial markers, regardless to the result of the bacterial culture. Any change in the patient's X-ray will be automatically treated with a new antibiotic. The end result is, while you are using all of those antibiotics, what do you think will be the environment for the bacteria when that patient will develop VAP or CAUTI or CLABSI? The bacteria which is already present now are already resistant bacteria. That's what we call the collateral damage. Collateral damage is very well known. Whenever you use an antibiotic, you kill the sensitive bacteria, and the only remaining one will be the resistant. So under the continuous pressure of an antibiotic, only resistant bacteria will grow, and eventually you will have only ESBL producing organism and only carbapenem resistant organism in your field by the time the patient developed the VAP or CAUTI or CLABSI. So what you are expecting, it's a loop of resistance. You excessively use the cephalosporin and quinolone, you increase the ESBL. In response to the ESBL, you use too much carbapenem, you produce carbapenem resistant, and the circle will continue. That carbapenem resistance go to the Enterobacteriaceae, then it will go to the fermenting bacteria as well, like the Pseudomonas and Acinetobacter, and the story will never end. So the guidelines have told the physicians you can empirically use antibiotic in severely ill COVID pneumonia patient on the ventilator. But the reality is everybody was on an antibiotic, regardless to the result of the bacterial cultures, regardless to the result of the bacterial biomarkers. Everybody was on antibiotic. Everybody, the antibiotic was escalated, escalated, escalated without any evidence of bacterial infection. And then we ask ourselves, when infection does happen, how you will be able to treat it? You have already exhausted all your antibiotic armamentarium. So what you are expecting will be the VAP, CLABSI, and CAUTI bacterial causes of that. And then ask yourself, what will be the impact on morbidity and mortality of if all your VAPs, CAUTI, CLABSIs are caused by ESBL and carbapenem resistant organism? That's a problem because it's a serious blow to the concept of patient safety. So it looked like during the COVID-19, we were risking the patient safety by not implementing the proper infection control rules. We now know for sure why COVID pandemic seriously challenged the healthcare system. We learned the lesson, but we learned it the hard way. It's very easy during any crisis to tell the people, this is what you should do. But it's more important to join the team hand in hand and show them how we can do. It's very easy to tell you should do this, you should do that. What is more important is to join them and show them how we can do this, how we can do that. For the guidelines, it was totally dissociated from reality. And we have to understand that any guidelines should depend on realism rather than idealism. And thank you very much for listening.
Thank you very much, Dr. Ashraf Al-Houfi. And Dr. Ashraf maybe also directly he will answer individually the questions. So it's my pleasure to introduce is going to speak about multisystem inflammatory syndrome, kids and adult. Dr. Saeed, the floor is yours.
Thank you very much, ladies and gentlemen. Thank you for having me. Glad to be among you all, even from abroad. In the next few minutes, I will talk about the multisystem inflammatory syndrome in kids and adults. And I will try to highlight all the mechanisms that trigger that inflammatory process, talking about the clinical presentation and the similarity with other diseases, and a few words about the potential treatment. I will start focusing on one case that we had a few months ago. We have a boy, 8 years of age, had no relevant medical history, was doing well, no contact with SARS-CoV-2. And the 1st of May, remember that date, the 1st of May, he was spiking and having fever. He was admitted to the local hospital, which antibiotics was started. We don't really know exactly what was the origin of the fever at that time. And he had some mucocutaneous rash. He had obviously abdominal pain with diarrhea, and he was confused. 2 days later, in that local hospital, he was persisting having very high fever again and being hypotensive. An ultrasound of the heart showed an impaired liver function, and ejection fraction was about 22%, and coronary artery was normal. And that kid was sent to our hospital and referred for ECMO. When we start looking at the labs, we saw that there is obviously a high inflammatory values, about high values of the CRP. The ferritin was high as well. The creatine was high, and TROPS was sky high, and the lactate was 14.6 millimole per liter. Remember that the normal value in our hospital is 1.4 millimole per liter. What would be your diagnosis at the time, ladies and gentlemen? Are you really dealing with the sepsis of the toxic shock syndrome, of dealing with Kawasaki diseases, of some kind of viral myocarditis, something completely different? We'll go back to that case after main talk. I will highlight what coronavirus, and I think that all of you are fed up with the COVID-19 for the time being, but for very shortly. I mean, the coronavirus as a large family of viruses, some causes illnesses in human and other in animal model. Most common of the symptoms are common cold, flu-like symptoms. But a few cases, we have severe acute respiratory syndrome as the SARS and the MERS, as you guys know, in that part of the world in the Middle East. And in December 2019, there's another coronavirus that was emerging in Wuhan in China, and it was called the SARS-CoV-2. And when we tried looking at the data, a few days I was looking at the figure around the world, and you will see in that map of the global world, and you will see that we have almost 50 million cases that has been registered, while we have 35.5 million now that has recovered, and still we have 1.24 million of that with the fatality rate that's surrounding between 4 to 6.4%. And if you look to the map of the world, you will realize that we have several dots. The diameter of the dots is related to the number of the cases that has been recorded in that part of the world. But quite frankly, you will realize that we have a huge disparities in incidence between the countries. And that is very important. If you look to the Africa continent, you will see that the data is very small. Whether this related to the fact of lack of reporting cases, of lack of non-contagious disease in that part of the world, and maybe there is something in between, and I will highlight that in the few minutes. And there is as well a huge disparity in age, but the most common cases that we had in Europe as well, in different parts of United States, patients are quite asymptomatic. And most of them may have pneumonia, and a few of those cases having what we are calling the ARDS, acute renal failure, gastrointestinal problem, acute respiratory disease. But the most important that we realize that a few of those people will display some kind of aggressive inflammatory response, and that is very important to remember that. And as you know, ladies and gentlemen, that our human system has an exquisite mechanism capable to respond to different pathogens. And when we are dealing with COVID-19, our immune response required the activation of different inflammatory pathways. However, when this inflammatory pathways is somehow aberrant of excessive, it leads to to disaster, whether that we are talking about multiple organ dysfunction or leading to what we are calling the cytokine storm syndrome. And if you look at this slide, ladies and gentlemen, you will realize that the cytokine storm syndrome is an umbrella of terms which it encompasses different syndrome and system, what we are calling the macrophage activation system, the cytokine release syndrome that has been associated with different kinds of these malignant diseases, lymphoma and leukemia. And there is what we are calling hemophagocytic lymphohistiocytosis that has been associated with different viral diseases as well by different systemic diseases such as lupus or juvenile arthritis. And that is very important. And the cytokine storm syndrome has obviously been well studied in hemophagocytic lymphohistiocytosis. As you know, we have the familial one of the primary one, and we have the secondary one. The familial one, meaning that we have a homozygote deficiency of perforin pathway. Remember, for those of the secondary one, almost 40% has what we are calling heterozygote mutation of the same pathway. And for those who are not familiar with the perforin pathway, this slide will highlight that as well. I mean, if you look at this slide, you will see on the left part of your slide, the perforin-mediated cytolysis. As normally the perforin in natural killer cells of CD8 positive cells can be packaged together with other granules and secreted and the immunologic synapse to form a pore of the blue dots. If you look at this slide, you will realize that the blue dots are the perforin making some bridge of pore, allowing the granzyme to enter the target cells of infected cells in order to provoke some kind of apoptosis. That is very important. The second thing that you might notice on this slide, the fact that there is infected cell in contact with the natural killer cells of CD8 T cells, there is an activation of interferons. In order to activate that pathway, we need at least a perforin that should be secreted in order to allow the granzyme entering the infected cells, and we need to have an interferon. On the other side of the slide, you will realize, that in a mice model of hemophagocytic lymphohistiocytosis, the primary one was the perforin deficient mice, and the wild type, the normal CD8 T cells, you will see that there is a antigen present in cells, there is an activation of interferon, and there is a perforin-dependent killing cells are leading to what we are calling the apoptosis of cell. However, the perforin deficient mice, the mice that doesn't have perforin that could be activated there is a mutation in the gene that code the perforin system, you will see that two important things that has happened. There is no lytic activity of the infected cells. That's the first thing. The second thing, the fact that the antigen presented cells still alive, that there is a huge increase in interferon gamma. And therefore, you will see that for that reason, since that the interferon will remain very high, that there is cytokine-mediated toxicity. On the other side, since that the infected cells remain alive, that is a cytokine toxicity and hemophagocytosis, and that is very important. It leads us to activation of different cells, most often the dendritic cells, the macrophage and T cells, and there remain in activation reaction between the T cells and the macrophage, and that is very important from now on, whether that the infected cells are killed or not at that time, that there is somehow what we are calling the self-amplifying hyperinflammatory state. That is very important. That is some standalone mechanism that occur all the time, whether that the primary trigger is gone or not. As soon as we get that the self-amplifying hyperinflammatory state, we are dealing with what we are calling excessive immunoreaction or cytokine storm syndrome. And what happened when we are dealing with the COVID-19 and we are talking about the multisystem inflammatory syndrome associated with COVID? On the left part of your slide, you will see that most often when the body is infected there is a huge response of interferon gamma, which is the first major line of defense against different viruses, allowing together with the perforin, allowing the lytic cells. And you will see that some kind of inflammation, not that high, and you will see that in early INF response lead to the rapid viral clearance and less inflammation, and you will have mild symptoms. However, on the other side, for one of other reason, if there is a delayed interferon response and not very good activity of perforin as well, and maybe secondary to the high viral load of the genetic aspect of the host, that will lead to a delayed inflammation and interferon, and an increased inflammation leading to multisystem inflammatory syndrome in kids as well in adults. In 2020, there is a paper publishing some data with regard to patients having the COVID-19 in China, and compared the data with the hemophagocytic lymphocytosis and having a hemophagocytic score. That the score that we are using when we try to analyze the cytokine storm syndrome. And you will see that the pattern that we saw in COVID-19 and in Chinese population at that time, that was quite similar than what we see in cytokine storm mechanism. The only difference that has been shown at that time, and that is quite obvious, and we really don't know exactly what is the mechanism behind that, most often when we are dealing with the systemic diseases that are lupus, of other diseases, of HLH associated with EBV, of other viral infections, most often we have an increase in lymph node and enlargement of lymph node. However, in a few cases that has been subjected to the autopsy, and in China after dying from COVID-19, it seems that there is a necrotic aspect of the lymph structure, and we really don't know why. However, if you look to the other mechanistic involved, and in cytokine storm, you will see that you will have obviously hyperferritinemia, you will have a hypoferritinemia, you will have neutropenia, and so on, and elevation in different kind of inflammatory mechanism. And it's quite similar than we saw in different diseases such as macrophage activation syndrome or cytokine release syndrome, of different other diseases with that kind of cytokine storm, and that is very important. And it's about the kid. I mean, the pediatrician was most often, up to the May, something like that. Remember, the disease has been started somehow in December 2019, but there was not that much cases in the case. And for reason for that, that was 1 to 2% of the young people having COVID-19 report a mild symptoms, with the fatality rate that was very low, 0.09%. And if you look at the figure, on the left slide, you will see that there is the fall increase was very low in small kids, less than 50, the other less than 50, and in small kids less than 18 years of age. And that is quite surprisingly. Until somehow in May, beginning of May, there is some report coming from UK talking about severe disease phenotype associated with the COVID-19. I was talking about Kawasaki-like disease, of some kind of Kawasaki disease that was quite obvious, associated with hemodynamic disability, instability of the kids, and those kids may need an ICU, and those kids may need mechanical ventilation. Short afterward, there is a report from Italy talking about hyperinflammatory shock in kids during the COVID-19 pandemic, and it was talking about Kawasaki-like syndrome. In July 23, 2020, from New England Journal of Medicine, there is a series of cases that has been reported about 186 patients with multisystem inflammatory disease in kids, and talking about that those kids might need inotrope, mechanical ventilation, and ICU, and even a few of those might need ECMO. And if I try to summarize that, you will realize that the most thing that strikes me for the time being, is that there is some ethnicity group related to that case. And you will see that the Black population and Hispanic Latino population was quite high. For the time being, remember when I show you the global plan of the world, the Afro-African Black people seem not that obviously affected by the COVID, and we really don't know the time being why. However, the Afro-American and the Latinos display very high percentage of high risk of having that kind of syndrome. The second thing, most of those kids having similar pattern with shock toxic syndrome or Kawasaki diseases with some kind of mucocutaneous eruption. The CT scan of the lungs display the same pattern like we saw in a COVID patient in adults. And if you look at the other pattern, it is quite obviously that all have fever, like Kawasaki problem, cervical adenopathy. But more surprisingly, most of the kids, almost 80% of more than 80%, displaying gastrointestinal signs, while the respiratory signs were very low. And those who are familiar with Kawasaki syndrome, you know that we have more and more coronary dilatation. In that kind of population, we have only 19%, at least in that series, but we have more and more pericarditis and myocarditis, and 44% up to 86% in severe form. And that is something important to keep in mind all the time. As you remember, there is a confusing name, whether that we are talking about multisystem inflammatory syndrome in kids, of pediatric inflammatory multisystem syndrome, that's the same. The difference is coming from the definition that has been first published in the CDC, that talking about multisystem inflammatory syndrome, age less than 21 of age, presenting, having laboratory evidence of inflammation, and having at least one of two organ involvement and no alternative plausible diagnosis, and positive for current of recent SARS-CoV infection by PCR serology of antigen, of at least exposure within the last 4 weeks. However, the Royal College in UK was more talking about pediatric inflammatory multisystem syndrome, but we have the quite similar definition that side having fever, inflammation, neutropenia, very high CRP, and lymphopenia, and having some renal gastrointestinal neurological disorder, and excluding other causes that can cause that kind of symptoms, such as sepsis, Staphylococcus streptococcus, and infection associated with myocarditis, enterovirus. But the most important is that the SARS-CoV-2 PCR testing may be positive or negative. Now, most of the population was quite negative, but serology usually came later on positive, and we are talking about post-infectious phenomena. And if you look to this slide, I mean, it's quite cumbersome slide, but don't focus on all the things. The left part is the mild symptom of TNF is increasing very rapidly. There is a clearance of the viral load from the body. However, if you have symptoms that occur 2 to 4 weeks, later on, we have a delayed systemic inflammation with a very increase in different kind of inflammatory pattern. And what we have calling the pediatric inflammatory multisystem syndrome of multisystem inflammatory syndrome. However, the same pattern has been shown in toxic shock syndrome. There is some kind of coronary dilatation, as we saw in Kawasaki, and there is some kind of organ damage. But the difference between that, we don't really at that time exactly what really happened. There is some kind of genetic susceptibility. There is some aberrant lymphocyte function. There is some change in the pathogenesis of the virus according to the part of the world. We're still working on that, and I will give you some information shortly about that. And if you look at that population, that paper that should be published shortly, you will see that 71% of the people need an ICU. 60% are in shock, all need vasoactive drug, a few of them need mechanical ventilation, and even of those population may need ECMO as well. And that is 1.7%, at least in that kind of population. But if you look to the medication and the treatment that has been, firstly, all those kids were treated like Kawasaki, and for one of other reasons, I mean, that the results were obviously very good, by giving intravenous immunoglobulin, different hemodynamic support, and corticosteroids in some cases, and having antibiotic. Later on, when we realized that these diseases may be related to the COVID-19, there is some other new medication that has been started, such as in interleukin-1 inhibitor, of interleukin-6 inhibitor, other medication, remdesivir of hydroxychloroquine. I don't think that the last two medications are working for the time being, since that remdesivir is blocking the replication of the virus, but the replication has occurred a few weeks before, and hydroxychloroquine doesn't work at all in that kind of population. Well, what really we're dealing with is that Kawasaki disease, is that toxic shock syndrome, is that like hyperinflammatory diseases with COVID in adults, and that is very important. And if you look at the distribution in that systematic review, we realize that there is obviously some difference between the Kawasaki diseases and multisystem inflammatory syndrome. It seems that the cytokine storm syndrome occurred in old kids. 9 compared to less than 15 years, with the peak age for Kawasaki is 10 months. In multisystem inflammatory syndrome, moreover, we have diarrhea and abdominal pain, are in shock. However, the Kawasaki more often talking about the cardiovascular collapse. Think about the coronary artery aneurysm is very high in Kawasaki disease, less high in PIMS of MIS syndrome, have higher leukopenia and increased BNP, quite ethnic background. African, of Afro-Caribbean, or Afro-American, almost all the kids in Kawasaki disease is most often Asian. There is no gender difference in multisystem inflammatory disease, and mortality is obviously very high in cytokine storm diseases associated with COVID compared to the Kawasaki, was 1.7 compared to 0.01. And what's now the fact? I mean, although SARS-CoV-2 has not been definitely proven as a cause of multisystem inflammatory syndrome, association with highly pandemic region has really happened in Europe and USA, and less frequent in less pandemic places. Even that the virus has started in China, it seems that the pandemic was not that high as we saw in Europe and United States, as well as in, and that is quite important. And what the most important thing that when we are talking about the multisystem inflammatory syndrome, whether kids of adolescents, of young adults, really does not have that much lung involvement, more often gastrointestinal problem. And the hypothesis behind that is that the virus have changed its pathogenicity, maybe, lagged in the time, because they say at home in some country. Remember that in Europe, the schools was closed for almost a few weeks, and allowing the kids to be exposed at home, and maybe could be one of the explications. And most of kids test positive for antibody than for the virus within the PCR. And there is some kind of age dependent, and I will take 1 or 2 minutes to explain that. That's very important to talk about that. And there is some kind of the difference in nasal expression of angiotensin converting enzyme 2 receptor that has been used by the SARS-CoV-2 to enter the cells. And you know, when we are infected, the virus is coming to our lungs through the alveoli, and there is the S receptor of the virus is connected to the ACE2 receptor of the body, which increase the angiotensin, and through a new mechanism that is very important, and maybe we will have time to talk about that later on, through the kallikrein-kinin system, by secreting the bradykinin and increasing the capillary permeability, and provoking some kind of pulmonary edema. However, a second way to get in the body through the blood circulation, and will attack the pulmonary capillary endothelial cells by using the ACE receptor together with the use unit of the viral reaction, and having some kind of endothelial cells that are attacked by the immune system, and creating some local massive release of cytokines. That has been shown in some study in kids, and maybe there is a difference, and the HLA difference between the origin of those kids having that problem. The second thing, I mean, is that the mechanism, the fact that people, kids of adults having that symptom that displaying quite later on, is related to the fact that the SARS or the COVID-19 block different type of interval response, with the potential of outcome of delayed cytokine storm. And I showed you before that delay in that process lead to an increase in the cytokine storm, and provoking that kind of syndrome, which is obviously deleterious to the body and provoking some kind of multiple organ failure, and can be later as well. Very shortly, I mean, is that whether that we have HLA haplotype difference, or if we are talking about the higher viral load of human impair immunity disability, as we saw in the elderly people, there is some defective clearance of COVID-19, which is related to the fact that there is an early inhibition of the first reaction of interferon is not working, or there is inhibition of early innate response, which lead to overproduction of cytokines and chemokines as well, and hyperinflammation, which lead to the cytokine release syndrome, leading to the secondary hemophagocytic lymphohistiocytosis. Remember, in secondary one, there is 40% of the people are heterozygous of the gene coding for the perforin as well, and this will lead to the multiple organ failure as well. And I will finish, before finishing my talk, I will come back to our cases before. Remember the 8 years of age coming on the 1st of May, admitted to our hospital at the 6th of May for ECMO. And we start giving some fluids and giving some kind of vasoactive drugs. And we provide them high nasal flow oxygen. We start antibiotics and high doses of immunoglobulin and corticosteroids. And quite surprisingly, we were quite surprised to see that the shock was reversed within the 3 hours. Whether according to the high doses of immunoglobulin of other supportive treatment, we don't know. But anyway, it means that those kids were doing well. And remember, that was of the 6th of May. At that time, there is a few cases that that was been talking about the Kawasaki diseases, and that case was obviously recovering very gradually and was discharged on May of 13 from the ICU and from the hospital as well. And we will try to look at the PCR, which was twice negative. The CT chest was negative as well, but later on the serology became, for IgG, became positive. And to finish my talk, ladies and gentlemen, I mean the take-home message in case of defective clearance of the virus. There is a cytokine storm that occurred, whether that's related to the interferon, related to the kallikrein system or perforin system, that is very important. Most often a secondary or later in life form cytokine form event that delay form, those symptoms start when the infection of the contact of the first was 4 or 5 weeks previously. There is difference in nasal expression of angiotensin converting enzyme 2 that could be somehow age dependent or ethnicity difference. I mean that the current multisystem inflammatory system or pediatric inflammatory multisystem syndrome related to the COVID may have some overlap with the macrophage activation system, with the Kawasaki diseases, with the histio of HLH, of cytokine release syndrome. That is quite important, and with other diseases that we saw in malignant diseases and other systemic diseases such as juvenile arthritis or lupus, as I told you before. But the most important thing, what we have to keep in mind, not only treat the underlying trigger or the disease, but also treat the overlying exuberance of inappropriate immune systems, which seems to be the trigger of that kind, and self-amplifying and self-sustaining process that lead to multiple organ failure. And I thank you very much for your attention, and we'll be glad to answer the question. Thank you very much.
Thank you very much, Dr. Idrisi, for this nice presentation. I now introduce our next speaker, Dr. Abdou Khouri. He is a consultant physician in the Department of Emergency Medicine and Critical Care in the University of Franche-Comté Medical and Trauma Center, as well as the medical officer in the fire department in France. He will be talking to us about management on dispatching patients. Dr. Abdou, the floor is yours.
Yeah, thank you, Dr. Ashraf. Thank you, Dr. Ashraf. Thank you for inviting me and having me in this excellent conference. I'm trying to, can you see my screen? Can you hear me? Can you see my screen, Dr. Ashraf? Okay.
Just put your presentation.
Yeah, okay. Trying to share my screen.
To see you much like this, but anyway, we need your presentation as well.
Of course, of course, of course. Now here is it. Here it is. Again, can I see it? Yeah. Here it is, and I think you can
Yes.
see it now. Yeah. Okay,
Good
I'm
one.
sorry for that, because I'm having multiple screens and trying to share it as much as I can. Okay, so thank you again for inviting me. So I'll talk about the medical dispatch center and the advantage of this of having a medical dispatch center in dealing with a pandemic like the COVID-19. I do not have any conflict of interest. I have lots of acknowledgement for people I work with in the EMS systems in Paris, in Toulouse, or in Mulhouse, a county nearby. Today, since the March 11, you know, that's a pandemic of COVID-19. We have more than 50 million people infected, more than 1.3 million dead, unfortunately. And this disease, we are actually in the midst of the second wave. And early on this year in Paris, we've got some few cases, and we were from the first countries outside China to be hit by the COVID and to be having some patient by the COVID. And very quickly, we just understood that something running on, but we have never imagined that this will happen the way it happened afterward and the way it became a huge pandemic. We're still thinking that at that time, it was gonna be like the SARS-CoV-1 and like the SARS in 2003, and we will be able to cope with this kind of disease and with this kind of endemic, let's say. But unfortunately, it wasn't the case. But nevertheless, at that time, we opened up a line, a very quick hotline to people that really want to inquire about this COVID-19 and what a bit, let's say, a bit anxious about COVID-19 and having some relatives and friends in China, in the Far East, and didn't have much information about that. And at the same time, the Ministry of Health, this was Madame Agnès Buzyn, have said to everyone and have said on the press and on the media, please, if you have any symptom, call the 15, the number 15, the emergency medical number. And if you don't have any kind of symptoms, please call the hotline, and just to keep the line for emergencies and not only to have everything on this line 15. As you know, some of you know, here's France in the middle of Europe. I'm coming from the eastern part of France, Besançon region, near Switzerland, near Germany, and near Italy, more or less. And it's a beautiful town. We're having a level 1 trauma center, and that's my playground. And in the early phase of this disease, we decided to bring all the people to our referral hospital. Everyone infected with COVID, having symptoms of COVID and diagnosed with COVID, would have been admitted to our hospital. And in our hospital, we have dedicated beds, we have dedicated ICU beds with a negative pressure room. But the reality was beyond all this, and we very quickly understood that we cannot cope with this by doing this model, and you have to change completely our model. Why we understood this very quickly? Because in Italy, it started the disaster. And in Italy, and the region of Bergamo was hit very severely and very quickly, with lots of people arriving to the emergency department and almost lots of deaths at the emergency department and outside the emergency departments. And people were struggling to admit all of them in the critical care. We're not very far from Bergamo. We're around like 500 kilometers by car, and we cross Switzerland. But we have lots of interaction with the region of Milan, of Bergamo, with the northern Italy, because our industries are really related to the industry in Milan and in Switzerland. We're coping with lots of microtechnics, and all this area in Europe deals a lot with the microtechnics. So we have lots of interactions with them. And in our center of our core center, we just started to notice a bit of activity related to COVID, but we weren't really tracing them at that time because we were still sporadic, and we didn't really understood the outcome of what was happening in Italy at that time. But very quickly, during the same period of time, we got a big cluster in a church in the religious assembly in Mulhouse. As I told you, Mulhouse is a town around 150 kilometers from Besançon, and it's really near our region. So we got a big cluster there, more than 1,000 people infected, and this started to spread all over France and even all over Europe. And at this time, we got more and more people calling the dispatch center. Usually in our dispatch center, we have 8 to 12 dispatch assistants, depending on the timing of the day. and on the weekends, and you have 2 to 3 emergency physicians and 3 to 6 general practitioners, that all of them are answering the phone and giving teleconsultation, giving advices on the phone, sending GPs, general practitioners home, but also sending ambulances or sending advanced paramedics, or what we call here in France, mobile intensive care units, that are staffed by emergency medicine physician and emergency nurse and the driver that are really, they know how to deal with emergency medicine, but all kind of critical care job. And at this time, usually in our dispatch center, we have around 600 cases every 24 hours. Our area is not that big. We are dealing with 1.2 million inhabitants, so not that big, much less than Dubai, for example, or much less than United Arab Emirates. And usually we have 600 calls every 24 hours. But shortly, this started to raise, and what you see in yellow are the cases of COVID calling our dispatch center, and we understood that things are becoming serious more and more. And at this time, we open up our crisis unit, another dispatch center dealing with the crisis. So all the calls related to COVID, we go to this special room, and we stop this room by our emergency physicians, of course, but also we got the help of our emergency medicine residents that came and enter the phone and give advice on the phone. And our first algorithm was very simple. When the people were calling the dispatch center, if they don't have symptoms, we're very quickly getting them back to the hotline that where people were answering their inquiries and their fears. But when they started to have symptoms, mild or strong, depending on the symptom, if it's mild, we were giving them advices and confine them home, awaiting the testing. And do not forget that at that time, or the first phase, unfortunately, we didn't have much testing. We just was testing at the hospital and severe cases. And if they have strong symptoms, at this time, our emergency medicine residents were giving the call to us, emergency physician, and the emergency physician dispatcher was taking the appropriate decision, either by sending the patient with the ambulance to the emergency department, or giving much more advices and telling the patient to call back if the symptoms are getting more severe. And then day by day, as you see, the calls were rising and more rising, and we increased our capacity in our crisis unit, and we opened up another crisis unit, and we were get some help from our medical students, because all the confinement have started in France and the universities was shut down. So all the medical students came to our dispatch center and came to other departments also to help the physician, help the healthcare workers deal with this pandemic. And the NGOs also, like the Red Cross, like the Popular Security, came also to answer the phone. Always the same model, saying that if you have symptoms, we give you we dispatch the call to the physician. If you don't have symptoms, we go to the hotline. And more every day, we increase this room, and up to having 25, 30 people in the room calling and giving advices and dealing with this crisis. At the same time, also, with our geriatrics, we open up a special line for retirement houses and specialized nursing houses, not to have all the people coming to the emergency department, not have to have the elderly people that were confined in these houses, but to make them come to the emergency department and get either infected or just get more and more burden on the emergency medical system. And as this was increasing day by day, week by week, we were strengthening all this, and we are giving lots of advices, and we are confining lots of people home. Once again, we didn't have that much test at that time, so we're really dealing this on the phone and more confining people at home. And if people having severe symptoms, we were sending for them ambulances. And as you see here in the figures, we went up to 1,600 cases all over as a peak, but it was steady over 1,000 cases every day during all the pandemic, all the first wave, up to mid-April almost. So we're giving lots of advices. We're confining lots of people home. Of course, we're admitting, but if you see, we're having around 800, 700 cases just for COVID. All in all, patients were still also ensuring the regular emergencies. So we're having more than 1,200 people calling every day for having medical problems and having COVID. But if you see the figures here, in the red one, you have the number of people from COVID calling for COVID at the peak, 800 or something like that, similar. But our transportation of the patient were very low. On the left axis, you have the calling people, And on the right axis, you have the ambulance transfer to the emergency department. To all emergency department, we were transferring only around 10 to 20% of all the people that were calling for COVID. So we're really protecting the emergency department not to crash, and protecting the hospital all in all not to crash. Dr. Ashraf have said and have talked about stopping all elective surgeries, stopping all the consultation activities, OPDs, and all that stuff. We're doing the same, but nevertheless, all our hospitals were completely overwhelmed by people having COVID, but not only having COVID, but also we were still dealing with emergencies. When you have a heart attack, you should not die of heart attack because there's COVID around. We have to go and bring you to the cath lab, so not to make you lose chances to have good care and the good standard of care. So we've worked a lot on that, and we really eased the burden on the emergency department and on the hospital and on our ICUs by doing this. And at the same time, we've done 2 pathways in our emergency department, and one pathway was fully for COVID people that were doing the triage on the door, and at the same time, the other regular pay people were coming to the emergency department. Like everywhere in the world, we've noticed a huge drop in our admission, our regular patients' admission. Unfortunately, surprisingly, all our regular patients have disappeared from our emergency department. Something really incredible. But anyway, we've just noticed that like everywhere else in the world. At the same time, what we've done in Besançon was applied also in Mulhouse. Mulhouse was a huge cluster. In the eastern part of France, we've got a huge, massive influx of people having COVID, and they were obliged to do lots of transfers from the region outside this region to other parts of France, to Germany, and to Switzerland, to be able to admit all people in critical care. It really was really drastic and really massive influx of patients. Anyway, in their way of dealing with the crisis with the dispatch center, they've done the same also, and they've have lots of people calling, but at the same time they've sent less and less ambulances, and they've seen in that emergency department the people the regular emergencies have really drastically dropped in the emergency department, like we've done, like we've had in Besançon. In Paris too, in Paris, and you see Bergamo, Paris, and Besançon. In Paris too, they were still having also same issues. Lots of people calling. Usually in Paris, they have between 200 to 2,500 calls a day. The patient calling the 15 a day. They've risen up to 8,000 with more than 5,000 patients calling a day for COVID. And even this, they also send less and less ambulances. And you see on the graphic on the right side, they at the peak admitted around 350 patients in their 10 emergency departments. There is 10 emergency departments in inner France, inner Paris, sorry, in inner Paris. They've barely admitted 300, 400 patients all in all, which is usually regularly only one emergency department have more than 200 patients a day. So you see also this kind of regulation and this kind of dispatch and giving advice on the phone and sending general practitioners at home have really lessened the burden on the emergency medicine system all over France. In Toulouse, it was the same. They also upgraded their answer. Medical students have came and have really helped a lot in taking the calls and in dealing with these patients. And as you see, also they've got up to 1,500 calls a day at the peak, and at the same time, almost 1,500 patients calling, and as a maximum 300 ambulances going to the emergency department. So you see, like up to 20%, only 20% of all these people calling and having COVID have been directed to the emergency department. So now we are in the midst of a second wave, as you see, and you see the figures. The first wave was really huge, 600, 800 people calling. Now we're around 200 people calling. We're having less and less patients than the first wave, although we still have lots of patients. Why we still have lots of patients? Because in this phase, we just tried not to stop all elective surgeries. Of course, we stopped 20%, 40%, according to the region in France, according to the departments and to the cities. But we're trying to continue to still operate on people and to still handle people with cancer, handle people with other problems and other diseases, and not to lose lots of chances for them to get of being treated and of being followed up by the regular practitioners. So that's why we still have lots of people in the emergency department and lots of people in the critical care, but at the same time, we have less COVID than we have in the first wave. Why? Because we've got lots of measures. We have the confinement, again, that it's working. We have the social distancing that works also. We have more and more masks. We're using hydroalcoholic gels. We're aerating our rooms. So measures are being applied more and more. And that's why we're having this result without confining 100% as we've done in the first phase in March. And we see the same application, less people calling, but at the same time, we're admitting less and sending less ambulances, although at this time, we're sending around 50% of these people calling us to the emergency department, or we're sending to them ambulances to just check on their vitals, especially on saturation. Why I'm doing this? Because we know more and more the disease. We know that it's a problem for oxygen, and we should maybe use oxygen very quickly and very early. And now we just have set recommendations 2-3 days ago with the Ministry of Health on how to put oxygen at home for these kind of patients. So we're discussing yet if it will put oxygen straight from the beginning, or we just bring them to the hospital first, assess them, and then send them home back with the oxygen, or even with high flow oxygen at home also. We're still debating this. So what is positive in all this? First, the emergency medicine system is really in the center of the major healthcare response, and it showed in the first wave and it's still showing in the second wave. Medical dispatch centers have played a major role in lowering the burden of the hospitals, and it aims at flattening the curve. We flattened the curve in the first phase, and we're doing the same in this wave. So far in France, we are not really above the curve. We're not above the line, above the threshold. We're still having capacities to hospitalize patients, and we're still having lots of issues, lots of things to do, and lots of transfers between hospitals. Are doing lots of transfers between hospitals to keep on having being able to treat all patients and not to left over anyone. And once again, the medical dispatch center is playing the role of conductor in the orchestra. It knows everything is happening. At the same time, it can alert on early outbreak of disaster, early alert, because when you call the dispatch center and you're having 50, 30, 60, 100 calls related to the same issue, related to the same symptoms, we can really alert that something happening. And this is what happened in our pandemic. And we knew exactly when the pandemic have started in France and how to deal with it at the beginning. And finally, thank you for listening to me, and it's a tribute to all my team in the EMS system in the Semi-25 in Besançon. Thank you.
Thank you, Dr. Abdul Khouri. And if you don't mind to stay with us till the end of the session to answer the question and for discussion. So it's my pleasure to introduce our last speaker for this session, Dr. Frank Van Haren. He is an intensive care physician, director of intensive care research, state of medical director, Donate Life ACT, adjunct professor, University of Canberra, associate professor, Australian National University, and adjunct associate professor, University of New South Wales, Australia. He's going to talk about nebulized heparin as a treatment for severe COVID-19. So Frank, the floor is yours.
My name is Frank Van Haren, and I'm from Canberra in Australia. First, I'd like to thank the organizers of the conference for inviting me again to do this talk for you. And today I'll be talking about new and emerging COVID-19 therapies, and in particular, I'll talk about nebulized heparin as a potential treatment for COVID-19. I have no relevant disclosures for this presentation today. And just to sort of recap the timeline of COVID, and I know that you all know this, but I continue to be amazed by how quickly we had a lot of information about COVID. So of course, the first cases were identified at the end of December 2019, and then just over a week later, the DNA gene sequence was already submitted to the gene bank, which was quite amazing. Of course, within a month of the first cases reported, we started to understand how exactly the virus binds to the human cells and enters the human cells using the spike protein, which then hooks up to the ACE2 receptor. And that's important, as I'll show later, for potential treatments and targets for potential treatments. And then finally, of course, about a month later, after the first cases were reported, it was clear that there was human-to-human transmission, and the pandemic started. Just a few hours ago, the WHO sort of overview of cases in the world showed that the dashboard shows that there's almost 50 million confirmed cases, and it's the number of deaths is going up to 1.5 million. Now, it's important to realize that these are only confirmed cases, and estimates of the true prevalence of COVID-19 are much higher, possibly around 800 million and 1 in 10 people in the world. And of course, there's also a significant additional mortality because of the pandemic, not directly because of COVID, but because of other effects of the pandemic. It's important to point out that there's an enormous amount of COVID-19 research that kick-started early in the year, and when you just look at the number of articles published on PubMed, is going up to 70,000 articles on COVID-19, and already there are 144 clinical trials that have been published, of which 74 were randomized clinical trials. This is just what's happened so far. There's also almost 4,000 listed studies on clinicaltrials.gov, with almost 2,000 studies currently recruiting. So there's really an enormous amount of research going on in the COVID-19 area, as would be expected in a major pandemic. So this is obviously basic what works in terms of trying to prevent the spread. Hand hygiene is important, as we all know, social distancing, and I think the wearing of masks is important, face masks as well, provided that you actually put it on correctly. The disease spectrum of COVID-19 was first described by the very large case series from the Chinese CDC, and that showed that the majority of people, over 80%, only have a mild disease with some pneumonia or even no symptoms at all. About 14% have more severe disease, and 5% of patients with COVID-19 will have critical disease, including the need for intensive care and mechanical ventilation. This more severe end of the spectrum, so once patients get hospitalized, they have a 10 to 25% risk of needing mechanical ventilation, and if that happens, those patients then have a mortality of over 50%. Now, one of the things that was put out early on in the pandemic was that these patients who develop severe respiratory failure and need to be mechanically ventilated seem to have an unusually high respiratory system compliance, and it was suggested that these could perhaps be new types or new phenotypes of ARDS. So we had a look in the LungSafe study that the original study we published 4 years ago now, but we went back to the database because that is the largest ARDS study that's ever been done, and we have an enormous amount of useful data in the database. So we went back to the database and looked at compliance in ARDS before the pandemic in the LungSafe database. And we found that of 1,100 patients where that compliance data was available, we found that 3/4 of these patients have a low compliance. So they have the stiff lungs, the typical ARDS stiff lungs, and that was called phenotype H by the people who thought that maybe COVID has new phenotypes. Phenotype H for high elastance, which is low compliance, of course. But in the same database, we found that more than 12% had very compliant lungs. So these lungs were not stiff at all, and they will be called phenotype L, or low elastance or high compliance. So when we combined that, we found that 1 in 4 patients had a compliance over 40 and 1 in 8 a compliance over 50. And with that, we could show that this high compliance in COVID-associated ARDS is certainly not new. We already saw that in significant numbers of patients in LungSafe before the pandemic. And of course, in the same paper that was published just recently in the Blue Journal, we also highlighted the relationship between compliance and hypoxia in LungSafe in non-COVID ARDS. And as you can see here, there's really no clear relationship in terms of compliance and hypoxia. And patients with high compliance, so the opposite of stiff lungs, can still have very significant hypoxia in pre-COVID ARDS. So let's quickly look at the pathophysiology of COVID-19 lung injury. Important, the first step, of course, the virus needs to enter the cell, and as I said before, it binds to this receptor with its spikes, the spike protein receptor ACE2, and because of hijacking of that receptor, the angiotensin II is then not broken down and will cause, via the type 1 angiotensin receptor, it will cause vasoconstriction and lung injury. So that's the first step where this virus causes lung injury. Secondly, there's a significant coagulopathy that's been well described now, and that coagulopathy through fibrin contributes to the formation of hyaline membranes in the alveoli and microthrombi and also major thrombi in the pulmonary circulation. And of course, in the past, we've already seen how that works with electron microscopy, where fibrin strands in the top image enter the alveolar cell and then form the network where neutrophils attach to and cause an inflammatory response. This coagulopathy and this vascular thrombosis is quite significant, and it's more pronounced in COVID-associated ARDS than in non-COVID ARDS, as was elegantly shown in this study and also in other studies. There's significantly more thrombosis and more pulmonary embolism in COVID ARDS than in non-COVID ARDS. The other important part of the pathophysiology is the inflammatory response through the resident alveolar macrophages, who then go on and become activated and release pro-inflammatory mediators. There's a significant hyperinflammation in the lungs. It was initially thought that there was also a cytokine storm systemically, but that's perhaps not so clear. Very elegant study by my colleagues from Nijmegen in the Netherlands, Matthijs Cox and co-workers, who showed that the cytokine storm in COVID-19 ARDS compared to, for example, sepsis with ARDS is actually lower. So COVID-19 with ARDS has lower TNF concentrations, has lower interleukin-6 concentrations, and has lower interleukin-8 concentrations. So maybe there's not a systemic cytokine storm, at least not in all patients with COVID-19 ARDS. Another part of the pathophysiology and the lung injury process is the formation of so-called DNA neutrophil extracellular traps, or DNA nets, and these cause significant lung injury as well. So the neutrophils are activated and then release extracellular DNA and cytotoxic histones that further causes lung injury. So because of this pathophysiology that we now understand quite well, the typical therapeutic targets would include vaccines, antivirals, anti-inflammatory drugs, anticoagulants, and specific antibodies. So what does not work? Very briefly, of course, we know that hydroxychloroquine and chloroquine are no longer recommended because there's a lack of clear benefit and there's potential toxicity. The former President Trump also recommended that you shine a bright light inside your body or drink or inject disinfectants. And of course, these are nonsensical treatment proposals. There was a lot of hope that convalescent plasma would work in these patients with severe COVID-19. Unfortunately, as was published just 2 weeks ago, convalescent plasma doesn't seem to be effective for COVID-19. Antiviral remdesivir, there's a clear signal of that. It's nicely summarized in this editorial. There's a clear signal that there's a modest effect of remdesivir, mainly in moderate COVID-19. Problems, of course, include that it's expensive, it's not widely available, and there are some remaining questions such as which patients should we give remdesivir to, how long should we give it for, and if you use steroids, is there an additional benefit over steroids? Now, another speaker in this symposium talks about the steroids in COVID-19, so I'll skip that, other than to say that steroids have a clear beneficial effect on mortality in severe COVID-19. Then there's a number of treatments that may work. One very promising treatment was targeting interleukin-6, because in the initial reports there was a high interleukin-6 level in COVID-19. And there's a number of studies that looked at this, and summarizing these studies suggests that the observational study that was done initially, which was quite large, had a positive effect on mortality, but in the 4 randomized controlled studies that have been done since, there was no beneficial effect on mortality. And combining these studies leads us to the conclusion that at the moment, the findings do not support the routine use of this interleukin-6 antibody. There are 5 more trials currently going on, so that may change once these studies come out, but at the moment it doesn't seem to be warranted to give that in all patients. We're working on another treatment that is, we think, quite promising, and the rest of my talk will just touch on nebulized heparin as a treatment for COVID-19. We've published the scientific rationale and the biological rationale in this paper a few months ago. And we are currently doing a number of studies around the world trying to get evidence that this is actually working. So this is Barry Dixon from Melbourne, who started the first study in Australia, and also who has done a lot of work over the last 10 to 15 years with nebulized heparin as a treatment for ARDS. So how would nebulized heparin work? Well, remember, first of all, this virus needs to enter the cell through the ACE2 receptor. And very interestingly, unfractionated heparin stops the virus from binding to ACE2. It basically hooks up to the spike protein, induces conformational change in the virus, and the virus can no longer enter the cell. This has been really convincingly shown by my colleagues and co-workers in the United Kingdom. This was just published a few days ago in the British Journal of Pharmacology, where they found that unfractionated heparin, but not low molecular weight heparins, unfractionated heparin has a very strong direct antiviral effect on this SARS-CoV-2 virus, which is an important part of the treatment rationale. Secondly, of course, heparin is anticoagulant, so it stops these problems with the hyaline membrane formation and also the microthrombi in the vascular system in the lungs. What most people don't know, but what has been extensively investigated over the last 50 years or so, is that heparin is a very strong anti-inflammatory drug, and it reduces these pro-inflammatory mediators. And finally, and that's also been shown very nicely in experimental studies, heparin reduces these neutrophil extracellular traps that are causing lung injury that I mentioned before. Finally, heparin also is a mucolytic drug, and it's used extensively in cystic fibrosis patients in inhaled form. So is there any evidence that unfractionated heparin nebulized improves lung injury? Well, again, I'd like to point you to that paper that we published, but in summary, there's a lot of evidence, actually, preclinical evidence in the lab and in animal experiments where all the evidence points towards an improvement of this pulmonary coagulation problem, less inflammation, and an improvement in oxygenation of lung injury models. Clinical studies, this is all pre-COVID, clinical studies of acute lung injury, for example, in burns and ARDS, also show reduction of coagulation problems, reduction of dead space, reduction of lung injury, and an increased number of days free of the mechanical ventilation. The most important clinical study so far has just been accepted for publication. It was led by Barry Dixon and co-workers, and I was part of that study as well. This was a phase 3 randomized controlled study in 256 patients with ARDS or at risk of ARDS. And the study is basically a positive study that showed that nebulized heparin compared to placebo reduced lung injury, reduced the incidence of new ARDS, reduced lung injury score, and improved recovery with more survivors at home at day 60. So what are we doing at the moment? We're basically running two meta-trials. Meta-trials are prospective meta-analysis of studies that are, of individual studies that are going on in separate countries. So we have the Charter meta-trial, which is a meta-trial of studies that are being done in Australia, Ireland, the UK, Spain, the US, and Belgium, where we study nebulized heparin in patients who are mechanically ventilated in intensive care with the primary outcome alive, so mortality alive, and ventilator-free score on day 28. So this study is currently recruiting. If anyone who's listening to this talk would like to join the study, please email me. We'd love to have more sites to help with this study. The other study that's currently recruiting is a meta-trial of patients who are not in intensive care, but hospitalized patients with COVID-19, the Inhale HEP study. These are the countries that we're currently recruiting patients in. A similar protocol where we give nebulized and unfractionated heparin to patients in the hospital who are not yet in ICU, with the main primary endpoint, the need for invasive mechanical ventilation, and a number of secondary endpoints. Again, if anyone would like to contribute to any of these studies, please get in touch with me. Just before I end, I just want to leave you with something here from one of my colleagues in Argentina, who is also doing the study, but this was just some experience before she started the study. And there were 6 patients that she treated with nebulized heparin. And some of these patients were very close to needing intubation and mechanical ventilation. And she started nebulized heparin, and these patients then improved quite significantly and went home with just oxygen and nebulization, and went home in 7 days. And the nurses in that hospital then called this treatment a miracle nebulization. Now, of course, this is not science. This is just some early experience. And this is exactly why we need to do the randomized controlled studies. So in a nutshell, in summary, nebulized heparin as a treatment for COVID-19 has a strong rationale to test because it's antiviral, and this is quite important. It's an antiviral drug, unfractionated heparin. It has the obvious anticoagulant effects, the anti-inflammatory effects, and it helps also with the mucus. There's a strong rationale because we already know that it's very safe, and we already know that it works in other studies of lung injury and ARDS before COVID. So in conclusion, when you look at COVID-19 treatments currently available, well, there's an enormous amount of research going on and there's a lot in the pipeline. We have a reasonably good understanding of the pathophysiology. I didn't talk about vaccines, but I think there's an uncertain expectation of vaccines in terms of are they going to work and how long will the immune response that vaccines induce, how long will that immune response last and will it actually protect? There's currently a limited number of effective treatments, but as I said, there's a lot of promising treatments currently in the pipeline, and so watch this space. With that, I would like to thank you for listening to my talk. Thank you very much.
We received a question online. If you are with us, if you can confirm that you can hear me, if you can answer.
Yes, good morning. I'm online. How are you?
Yeah, I'm okay. That was a very impressive presentation. The question is that specific for the nebulized unfractionated heparin, or it can be extrapolated to any other anticoagulant? You mentioned unfractionated, not low molecular weight heparin. So somebody from the audience did ask, what about the NOAC, for example?
Yes, so that's a very good question. The study that I showed in my presentation that's been published looked at other types of heparin, so low molecular weight heparin, and compared that to unfractionated heparin. So low molecular weight heparin have a very weak antiviral effect. And unfractionated heparin, the antiviral effect is about 100 times stronger than low molecular weight heparin. Now, there are a number of other anticoagulant targets that people are studying. When you look at clinicaltrials.gov, there's actually quite a number of specific studies looking at anticoagulant treatments, both directly administered to the lung, but also systemically. None of these studies so far have either finished or have shown any benefit. These studies are mainly targeting the coagulation problem. These anticoagulant drugs are not used because of its antiviral effects. They're mainly used to sort out this problem with microthrombi and PEs, and that's also the reason, for example, why there are many studies at the moment looking at systemic anticoagulation, so systemic therapeutic heparin in severe COVID-19. For example, the large platform trial REMAP-CAP is also investigating it, and a number of other studies. I think that's very reasonable, but I think doing that you only attack one part of the pathophysiology, and it's much more complex, as I've shown. And this antiviral effect of heparin may also be important when you consider perhaps early treatment. This is something that we're looking into as well. I've shown the studies that we're doing in hospitalized patients and in ICU patients, but there may be a role to study this in the community, and we're working on it as well, where the antiviral effects could perhaps stop the infection from getting worse, but it could also perhaps stop the actual spread of the virus if the viral load is reduced by unfractionated heparin. But this is all experimental and being studied at the moment.
What about the dose and the frequency and the duration? For how long are you going to use it? And is it for any patients, or there is a severity score you want to add?
Very, very good question. And we are asking the same questions. There's no answer to these questions just yet. The dose is based on previous ARDS work. And we know that we actually need to use quite high doses of nebulized heparin. So we use a fixed dose of 25,000 units every 6 hours. So that's a very high dose, nebulized. We use a specific nebulizer, a vibrating mesh nebulizer. And with that, from the dose studies that have been done, about 20% of that enters the alveoli when you use the vibrating mesh nebulizer. When you use other nebulized techniques, it's perhaps less. So the ARDS and acute lung-induced dose finding studies have shown that that's the type of dose that we need to look at for the severe cases for ARDS. And we extrapolated that to the hospitalized patients, similar doses. But some of the studies that are researching this under the meta-trial umbrella use lower doses. So there's also a study in Argentina that looks at this, and they use 5,000 units instead of 25,000 units every 6 hours or every 8 hours. Then of course the question is, what dose should we test for the early studies when patients are still at home in the community to stop the spread or to reduce the viral load? And there's basically no answer to that question. But again, dose finding studies that have been done extensively pre-COVID suggest that we need to give quite high doses. So we would be thinking in the same range of 25,000 units.
Thank you very much, Dr. Verhaeren. At least we are now waiting for something which is working, because a lot of preliminary data came from a lot of interventions, and everybody is giving us hopes, and then we realize later on that it's not working. I knew also that Dr. Hashimi is still with us online. There was a question for him about the COVID-19 sepsis spread and what are the challenges which we're facing in preventing it, and he opted to answer this online. So Dr. Hashimi.
Good afternoon, everybody. Thank you for having me. I think that the question is related to the fact that the people having the ACE inhibitor medication drugs of certain medication. I think that the data has been shown before that those both medication doesn't work anyway, whether that we have it in protecting or in aggravating the diseases. I think that there is no big issue. We were a little bit afraid when we saw that the ACE receptors are involved, and we were wondering whether that the drugs such as ACE inhibitor or something of a different kind of drugs in the same category would influence the evolution of the course of the disease. But it seems indeed that that this was not the case.
There was one extra question for Dr. Verhaeren again. If you are using the nebulized heparin, are you using concomitantly the anticoagulation, which is normally recommended in the COVID-19? And are you monitoring it by the D-dimer as well?
Oh, thank you. Those are excellent questions. So yes, you can give nebulized heparin on top of normal anticoagulation, including therapeutic anticoagulation. There is extensive experience with nebulized heparin not causing additional anticoagulation effects on a systemic level. So we're monitoring APTT, obviously, but APTT from the previous studies and also the study that will be published shortly in the Lancet, APTT does not go up with systemic, so there's no systemic effect or hardly any systemic effect of the inhaled heparin that we give, the nebulized heparin. In some of the sub-studies, we do monitor D-dimer, either in the bronchio-alveolar lavage or systemically, to see, but that's more like exploratory, to see if there's a specific subgroup that may benefit more from nebulized heparin and to sort of understand some of the mechanisms behind it, why it might work. But we believe that an elevated D-dimer or an abnormal D-dimer is not essential for this to work, because it's also an antiviral drug, as we've shown. So it would also stop the virus from causing more lung injury quite early on, would be the idea.
Thank you very much, Dr. Verhaeren. It looked like the issue of nebulized heparin is very hot. The people are keep on hammering us with questions and comments related to that. I really hope it will work and it will prove its efficacy in that particular context.
Can I please ask anyone who listens, and I've said that during my talk, We really need more sites. We really need more hospitals that contribute to the study. So if they can please get in touch with me, if anyone wants to contribute, that would be fantastic. It's the study, the pre-ICU or the hospitalized patient study is recruiting quite well, but the ICU study is recruiting slowly. And we want an answer sooner rather than later. So anyone who's keen to contribute, please get in touch with me.
We will consider this as a worldwide announcement for the people to contribute to that study. Hopefully we'll get the positive result. Thank you very much for our speakers for this session. And this will conclude our session for today. I will turn it over to Dr. Hussein to give the closing remarks.
Thank you very much, Dr. Ashraf. Thanks to all our speakers, Frank, Saeed, and Abdu, and all other prominent speakers who were with us today. I really appreciate your participation. Thanks to my attendee here and online. I hope that you enjoyed. The story will not close by today, and it's not going to close, I assume, throughout this year. Neither the COVID nor the ECC. We are still going to be, for the second time in 2 weeks, and the COVID talks will not finish. It will keep continue, and our fight together around the globe will also continue and stronger. You have seen how much studies, how much new concepts, how much change of approach to patients who have desaturation or have the influence of the virus in any kind of, in any part of the body, any organ. We have a journey to continue. We will continue, and I'm sure as a medical field member, we will win. As a human being, we will win the fight against COVID. United, together, exchanging our experiences, letting the information pass through continents and air, through communication, the telecommunication, and other ways. Thank you very much for being with us. It was great pleasure meeting you online. Looking forward, maybe in the next 1 or 2 years, to meet again and see you in 2 weeks, inshallah. Thank you very much, and wish you a good day. I hope you enjoy. Thank you.